Ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Yatupasa sote kuelewa ya kwamba maisha mema kweli ni afya bora. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Palipo chuki na ugomvi nilete upendo,
ili Wakenya wote waishi kwa upendo kwa kweli.
Palipo chuki na ugomvi nilete amani,
ili Wakenya wote waishi kwa amani tele.
Popote palipo na mtengano nilete umoja,
ili Wakenya wote waishi kwa umoja kwa kweli.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa amani tele.
Yelele yelele.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Sound check on 2. Mwalimu Emodia, huo wimbo unazungumzia masuala ya amani, na sote tunaambia Mungu nifanye chombo cha amani yako. Ni sala iliyofanywa na Mtakatifu Fransisi wa Asisi. Nitaomba tusimame sote. Tusimame kwa sababu bado kuna baridi, na mwalimu ukitupa huo wimbo nitaomba kila mmoja wetu, let us dance to the song and clap. God, make me an instrument of peace. Can you repeat with me? God, make me an instrument of peace. Go with me. God, make me an instrument of peace. Talk to yourself. Talk to yourself. God, make me an instrument of peace. Mwalimu, give us the peace and let us clap. Hata kama hujui wimbo, unasema tu Mungu nifanye chombo cha amani. That is a clarion call for us, because our country, we only have one Kenya. And if we destroy it, where do we go? Mungu nifanye chombo cha amani. Na tuimbe sasa kwa sauti kwaya, ndio tuimbe sote.
Mungu nifanye niwe chombo.
Let us clap all together.
Nisambaze amani duniani kote.
This, so we have introduction.
Light is the newborn screening. I would like to sensitize and say that let us continue to implement it all round, because every implementation that is delayed has a name behind it. For example, we have Joe Mudukiza. He recently passed away. Joe was a well-known sickle cell warrior and advocate. He started the journey back in 2016 with Honorable Isaac Mwaura. And what Joe's journey brought forward is the need for mental health support, because unfortunately at some point, he really wanted to go to Berlin to get euthanized. So I would like to say, as sickle cell warriors, we are really celebrated because of our, brevity, but we never really ask, what is the cost that we pay to be brave like this? Let us get our psychosocial and mental health support. Asanteni sana. And I would also love to say that I would want to work for my country. In October, I'm going to the International Sickle Cell Anemia and Thalassemia Conference in London. And I would like to say and show them that SHA is working. SHA has universal health coverage. So mukinishika mikono, I will be very happy to show this. And asanteni sana CHPs, Embakasi Central Unit. My mother is one of you, Nyamavila. CHPs, you're the ones who can help us to implement this thing of newborn screenings, because you get into homes, you can say and tell, this home has people who probably have the condition, and any hospitali, get the screening. Asanteni sana for holding my hand. Let us hold the hand of thousands more. Thank you.
A round of applause. Your Excellency, the First Lady, dignitaries in the room, maternal and newborn health champions, we have heard the stories. In every woman, every newborn, everywhere, we always face the sun. There are challenges, but let's also amplify the positive stories to encourage one mother and any newborn who cannot speak for themselves. Kindly let's give a last round of applause to our panelists as they leave the stage. Thank you.
Thank you very much, Dr. Juliet, for ably moderating that. You want to take a photo? Please come back. Thank you. Your Excellency, I also want to recognize our governors. Please join the photo. The governors in the house.
Yes.
Yes. Yes. Thank you. Thank you very much, Your Excellency, for that good gesture of warm motherly care. It's a milestone for these warriors to achieve this today. Asante sana. Next, we have it's my honor now, Your Excellency, to call upon our Director General to take the program from here, the Eweno Promise, turning commitments into lives saved. Karibu DG.
Thank you, Dr. Bashir. Your Excellency, the First Lady of the Republic, Mama Rachel Ruto, Cabinet Secretary for Health, on Aden Duale, Excellency Governors present, CEOs of our hospitals, senior officials from the ministry, our PSS, distinguished delegates, ladies and gentlemen, good morning. Your Excellency, I will take us through a few slides as to why the global community came with this every woman, every newborn, everywhere slogan. The reason was that progress towards ending preventable maternal and newborn deaths had stalled, and resources were now being channeled elsewhere. And what was the reason for this stall in progress? Basically, 5 things contributed to the slowness in terms of progress of accelerating reduction in preventable maternal and newborn deaths. One was the disruption caused by COVID-19. Both the non-medical countermeasures we put in place disrupted services. Number 2 was because of conflict. You saw in the earlier video that 70% of the maternal and newborn deaths happen in sub-Saharan Africa. And globally, the figure is actually 260,000 maternal deaths. 70% to 80% of that happens in sub-Saharan Africa. So conflict was a key driver in stalling the progress. Number 3 was climate crisis, either because we have floods and we have disruption in health facilities, or we have droughts and we have food insecurity, acute malnutrition follows, and definitely usually the first people who get affected.
Guests, our CHPs, CHPs oye. Habari ya leo, mko salama. Your Excellency, every woman, every newborn, everywhere has given Kenya a number that none of us in leadership can afford to look away from. Even as we celebrate the successes, every day we lose approximately 15 mothers and 92 newborns, many from causes we know how to prevent. And really allow me to acknowledge the presentations that have been made here before, the success stories that we have had, the issue of sickle cell. I'm sure when you saw the presentation from Jaramogi, TRH, you saw that there were 3 red places. There was the Nyanza and Western region, which I'm told is the malaria-prone region. Then there was a coastal area, but there was an island in the middle. That island is unfortunately Nairobi, but I'm glad to report that we're making strides. We set up our screening and treatment center at Kianda 42 in Kibra. We are screening in Mathare North now and at Ruta. And just for awareness for the mothers and the parents out there, I know our CHPs are able to direct people. It is good for them to know that we also have those services in Nairobi. But back to issues of every woman, every newborn, everywhere. I want to speak about how we will change these numbers that we've been told and give some examples from the capital city. Ultimately, our interventions on every woman, every newborn, everywhere will succeed, of course, county by county, facility by facility, household by household. The Ministry of Health, of course, leads with policy, but pregnancy happens in our communities, not at the ministry, hopefully. Antenatal care happens in our facilities. Deliveries happen in our maternity units. Emergencies arrive at our hospitals. And that is exactly where counties become central to the success of these initiatives. And I'm really glad, even yesterday, the President acknowledged the strong partnership between the ministry, the national government, and the county governments in addressing this. There are 3 delays that we must confront for us to sort this out. The first delay is in deciding to seek care. Then there's a delay in reaching care and the delay in receiving care once a mother arrives. In Nairobi, we've structured our response around these 3 delays. The first delay we close is taking health care to the household. The first battle is won or lost before a mother even reaches a hospital. Nairobi has 7,820 community health promoters who I'm very proud of, working across our city. These CHPs are the closest link to our mothers. They promote early antenatal care, follow up pregnant women, identify danger signs, and connect families to health facilities. Before, we used to tell people to go to hospital. These days, we take the hospital to the people through our CHPs, the strongest cog in the wheel of universal health care in our country. And we must appreciate the community health promoters. I'm glad that now we have gotten shark cover for all our CHPs. And we thank the President I'm glad all counties have now gotten on board. I signed the check in State House. It was a big check to pay for 6 months, and Duale is paying for 6 months, and plus the issues of the stipend. And thank you for the kits. And we're waiting for the 90 days. Now it is 89 days for what they're supposed to get. The second delay we must close, Your Excellency, our First Lady, is making sure a mother can reach care. Identifying the emergency is not enough. A mother must be able to reach there when she needs it. Nairobi County operates a toll-free number, 1508, that dispatches ambulances and coordinates referrals. And just the other day, we launched with the President 922 for the National Dispatch Center in collaboration with the ministry. In the last 4 months, our system has handled 4,573 emergency alerts and referrals, about 38 a day. We're achieving a 98% response rate, and this is critical for every woman, every newborn, everywhere. 54.6% of all emergencies handled by ambulances are maternity and newborn cases. So Nairobi 1508 and 922 are not just an ambulance number, it is part of our maternal and newborn survival system. Then lastly, it is closing the third delay. What happens when she arrives? This is the most decisive responsibility that county governments have, because there is very little value in reaching the facility if the facility is not ready to save a life. That means having the medicine, having blood, having a functioning theater, having newborn care, and having clear referral pathway when higher level care is required. I want to really applaud healthcare workers across the country, nurses, clinical officers, doctors. I want to applaud chief officers in the county governments, directors of health, our CECs, led by my CEC here. The work that they are doing is where the rubber meets the road. Your Excellency, many people may not know why I am very passionate about issues of maternal mortality. And let me tell you, my late mother had lost 3 children, before my eldest sister was born. She had difficulty with pregnancy. So the first 3 died. After she got the first 3, she was told that she can have only 2. And of course, you know African men, they want to have a boy. So my firstborn sister was born, and Marie. My dad was happy, of course, that's a child, but my secondborn was on the way now, the secondborn. Then when the secondborn came, Evelyn. Now, my mom had been told because with 3 losses, she can only have 2. But my dad said, lazima work. So he insisted. Now, I was born premature. And in the 80s, I think it was very difficult to get an incubator. I was asking Dr. Amoth, what are the statistics? And so because of that, I had to be taken to a different facility. I was in an incubator for a long time. And so, and now I'm here, by the way. I didn't, I survived. And when I became governor, I realized that Nairobi had no neonatal ICUs at all. And that information was from my CEC, my chief officers, my teams. And I said, this story must change. We have just seen Nancy Kerubo here. That child is one of the products of our neonatal ICU in Mbagathi that I made sure that we have. And in that Mbagathi, we have kangaroo, and in many of our hospitals. When you go to the kangaroo, we have now encouraged men, the fathers, to also do kangaroo. That's your mama peke yake anafanya kangaroo. Even the men. And whenever I go there, I encourage the mothers. I tell them, you know what? Don't worry if your child is born small. Even me, I was born small. Your child can become a governor, can become a lawyer, can become a doctor, just to give them hope in the community. Your Excellency, because of that, we have really scaled up healthcare in Nairobi. I am proud of the numbers. From 0, we have 23 neonatal ICU beds in Nairobi. We have 224 newborn unit beds in the last few years since I became governor. We have further expansion ongoing in Pumwani and Mbagathi. Mama Margaret Uhuru Hospital, which has 8 theaters, Mama Lucy Kibaki Hospital. We used to hear negative stories about Pumwani every day. We have recorded 0 maternal deaths. And that is the biggest maternal facility south of the Sahara, north of the Limpopo, delivering close to 16,000. The numbers went down last year because of mambo ya for wafanyikazi, but it's around, I think, 80 a day, 50 to 80 a day. And thank you, Dr. Christine. I must acknowledge, Christine is the CEO of Mbagathi Hospital. Dr. Saru is the one who spoke. Thank you. It's the same in Mutuini. It's the same in many of our hospitals. We have established 6 new maternity units in Ruai, in Kasarani constituency, in Riruta, in Dagoretti North constituency, in Pumwani Majengo, just here in Kamkunji constituency, in Kaloleni, in Makadara constituency, and 2 maternity theaters that are not there at Kayole 2. That is the lowest, the low level. Kayole 2 in Embakasi Central, and Madare North in Ruaraka. This is possible. So as I conclude, I don't want to take too much time. We also have, allow me to say, in Nairobi, in all our facilities, every county maternity, we have made sure there's heat stable Kabetosin to make sure that we strengthen our response to postpartum hemorrhage, as well as the intrauterine balloon tamponade that's used to control severe postpartum hemorrhage, where uterine massage has not stopped the bleeding. Your Excellency, I'm not a doctor, but when you become a governor, you must be a doctor, you must be a garbage collector, you must be a roads engineer, you must be a everything. You must be a lawyer. I keep saying you must have the mind of a CEO and the heart of a social worker to run this devolved unit. Your Excellency, I'm happy. I'm told in July we got a child of 650 grams. Last July, 650 grams, but survived because of the NICU at Mbagathi. I'll encourage all my colleagues to keep doing that throughout. So finally, of course, it's financing the frontline. Waziri Duale, you are a champion that this country appreciates. I don't know what you are doing in the Ministry of Defense. This is the real defense that Kenya needs. This is the real defense that Kenya actually needs. He has done great in the Ministry of Health, together with my brother, Oluga. Financing has sorted out so much for us through SHA. Financing the frontline through facility improvement financing. Your Excellency, in 2022 in Nairobi, we were getting around 700 million for all my facilities, 125. This last financial year, I have closed at 2.6 billion shillings that is staying within those facilities to make sure we have 90% availability of medicines and laboratory services. Our facilities are now doing outreaches. We've conducted more than 120 outreaches and in-reaches every month, bringing preventative and curative services closer to communities. Every death must teach us something. Infrastructure and financing are not enough. We need more as leaders, accountability, which is why together with the ministry and DHA and the COG, every governor in Kenya has a dashboard where every day they can tell how many births took place in their facilities, how many deaths, if any, took place in their facilities, and the interventions to make. That information is right at everyone's fingertips. We hold weekly maternal and perinatal death surveillance and response meetings. I will not continue with the speech, but just to add one element that I think is important that we've started in Kibra constituency. Early childhood development doesn't start when the child goes to ECD. It starts when the pregnancy occurs. It starts at the point of conception. We've started training our fathers. And we've told our fathers, one, when you shout and make noise at the mother in the house, the child can hear. Ukiwa mtu wa kuleta vurugu na shida kwa nyumba, mtoto anaanza kusikia. How you treat your pregnant wife is very important. Siku hizi sasa, kwa ile maeneo tumeanza training, wababa wanaingia wakiimba. Wanaimbia wamama, ndio mtoto atokee mzuri. You don't want to affect the mental state of your child because of shida zako za mtaa. Si ni kweli? So wababa, hii naambia wababa, come to the hospital for the antenatal and see visits with mom. Sisi tutawatrain na uingie ukiimba. Sawa sawa. Wababa hoye. Wababa hoye. Mtaimba. Kama mjui wimbo wa kuimba mnitafute after this nitawapatia wimbo. Maternal, the success is not just for mothers. It is both the father, the mother, and the community. Your Excellency, thank you for your commitment towards every woman, every newborn, everywhere. Okoa mtoto, okoa mama must be more than a slogan. It must be a national promise delivered by all 47 counties. May God bless all of you. Oh, I wanted to invite Waziri, but I want to ask for a favor. I know we are short of time. But kindly, if my vice chair of COG, who did so much work, you know when you're dealing with the bills, when you're dealing with the governors from 2022, kindly, Mheshimiwa Mudhomi Njuki, please come make remarks and then you shall now take it back to the ministry. Tupige vice chair. And by the way, Mheshimiwa Duale, Governor Mudhomi Njuki, the chair of health, Governor Sharif Nasir, the former chair of health, and the governor of Nairobi, all went to a very good school down the road, on Ngong Road. Thank you.
Thank you, Governor Sakaja. We must appreciate that that was the right person to speak today on behalf of the governors, because we all live in Nairobi and we're in Nairobi. Your Excellency, the First Lady, the Cabinet Secretary for Health, Adan Duale, my colleague governors, and our protocols observed. I may not have much to say, just to appreciate that the last 4 years has been a journey that Kenya needed. We started with the reforms that we had with the 4 laws that were passed, which has been the brainchild of the Kenya Kwanza government and the leadership of His Excellency the President. Those 4 laws brought the reforms that we needed today to bring us to where we are. I cannot figure out a country without SHA. I cannot figure out a country without the CHPs that we have today. The awareness that we are talking about today, which started much earlier in a smaller fashion by the counties in form of MPDSR, has been nationalized and coordinated. The effort of both the national and the county government that brings the synergy to ensure that mothers don't lose lives or even lose the newborns is critical and is a product of that synergy that we have between the levels of government. The health sector would not have been at a better place today if we do not have the coordination that we have, that has brought together all the health workers, irrespective of the space they occupy, whether it is CHP, whether it is a specialist in the ward and in the theaters. That has been very critical to ensure that all Kenyans are aboard in what we are striving to achieve as universal health care for everyone in Kenya. We want to make a commitment as the Council of Governors with my colleagues. Initially, health used to receive more or less the same equal funding with the other sectors in the devolved units. But today, every county spends or allocates approximately 60% of its total budget to health. And that tells you that in all the devolved functions that we gave the devolved units, health is at the top. It is at the summit. It is of critical importance because without that health, then all the other functions cannot be able to be performed. I do not want to overrate because it's not my day, but I want to make that commitment, Daktari Duale, that we, as we call you today, we are going to work with you to make sure that the coordinated effort that the ministry has already been able to initiate with us will realize the results that the Kenyans deserve. With those few remarks, I would like to take this opportunity to ask the chair of, with your permission, First Lady, the chair of health to make just one remark, or just make a remark, and invite the CSL. Thank you very much.
I think today is a day of being hijacked. Your Excellency, the First Lady, I think Governor Sakaja forgot to inform you as well that our next guest as well who will be having, the Deputy President, who was also in the same school with us. So there must have been something right about the school we went to. First and foremost, I want to congratulate. I've said this to you in person, Waziri, and to your PSs and to the heads of the different sagas, that congratulations for a very, very beautiful summit. It is truly an eye-opener, not just to us as industry players and movers, but also to the rest of Kenyans. Kenyans being able to realize what it is that their government is actually doing for them. The plans that were initiated based on the needs of the people till today where we are. So congratulations. It takes a lot of vision from a leader who sees a whole jigsaw puzzle in many, many different pieces. And for him to be able to put everything in place, especially when you have naughty children, and in a case like this, when you're being taken to court, when parliamentarians were not being able to understand, when, every single person, heads of facilities as well, in some instances, were not understanding what the concepts were. It has taken time, but today it is truly not just taking shape, but the fact remains, and it is an undisputable fact that SHA has been able to save lives. SHA has been able to save livelihoods on what it is that we do. I just want to add on something else, and I think it is important. We need to start having this conversation as well. The issue of early childhood does not begin when a child gets born or a child goes to school. I agree. A child actually, it's from conception. And this is scientifically proven. All doctors who are here will be able to agree that what it is that you do when a mother is pregnant has an impact. When you see levels of areas where crime is actually high, it is scientifically proven that what happened to that particular mother since the time she was pregnant and for the first 5 years, what it is that has been able to be done on that child. When we look at figures and we see that we are having babies that are born malnutritioned and severely malnutritioned as well, I think the conversation now needs to shift from the proposal that we should not only just be doing the element of treatment, but we should also be doing the element of ensuring that we do not have such cases happening in the first instance. And maybe proposal that we will be coming at as a council as well to work with the Able Ministry on matters to do with malnutrition and severe malnutrition on our children. I think this is going to go a long way and something that will be remembered, hopefully, for those who are going to come over after 2032. They will continue the journey where we were able to live it. With those very many words, I think it's my job to now invite the Waziri, who is, maybe we need to give you a title, the Defense of Health. Karibu sana.
Your Excellency, the First Lady, Mama Rachel Ruto, the Council of Governors led by the Vice Chair, the Governor of Nairobi, the Governor of Mombasa, I think I saw the Governor of Nandi, I don't know if there's another governor. And then we have the Chair of our Health Committee, Dr. Nyikal, our colleagues from both MOH and our county government, our valued frontline soldiers, community health promoters. Your Excellency, our First Lady and distinguished guest, This plenary brings us to one of the clearest measures of a health system performance. Whether a woman can go through pregnancy and childbirth safely, and whether her newborn receives the care required for that newborn to survive and to thrive. For too many families, that journey still carries avoidable risk. And today I want to say one of the reasons why maternal and newborn mortality is now becoming a national discussion is as a result of an encounter between our president and senior global leaders who raised with him and told him, Mr. President, you have done a lot, but you must address maternal and newborn issues in your country. And that's why, and I'm very happy and I want to thank our governors, when we isolated and said that 26 counties with high burden when it comes to maternal and newborn mortality, today I want to report very success stories working with the governors, Nairobi, Kisii, Garissa. These counties are also learning from counties that are doing very well. Our counties are doing the MPDSR. They're going from one county to the other. I think last month they were in Garissa. And Your Excellency, Mama Rachel, a woman may develop very severe bleeding. She might have a very high blood pressure or even an infection, while her newborn may be born prematurely, like Governor Sakaja. And now, you know, if he tells you I was born prematurely from his body size, you'll ask whether his story is adding up. What I expected him to be. But those who are watching us, premature birth is real, and it can produce a very strong, well-built governor like Governor Sakaja. So there is light at the end of the tunnel. But on May of 2026, our president launched Every Woman, Every Newborn acceleration plan. We were the first country, not in Africa, I think globally, to launch that. And what does that tell us? It tells us we must place maternal and newborn survival at the highest level of the national leadership. For us, we are very proud at the Ministry of Health and even our counties, that responsibility at the highest level is with President Ruto. And more importantly, the president backed his commitments with resources. Today, after consulting with the Council of Governors in our last summit, today, President Ruto's government has provided 4 billion shillings to all our health facilities, level 2 and level 3, where a mother will go walk in, deliver, fully paid by the government of Kenya within the primary health care fund. And not only for delivery, but for all the newborn care essentials. We have also provided, under the leadership of the president, 1 billion for life-saving maternal and newborn commodities. And KEMSA CEO is here. Dr. Wako, yes, with the full instructions that those commodities that will save a mother must be available in every facility in our counties, because it's paid for by the government under the leadership of our president. And that those essential products are for life-saving maternal and newborn commodities. Then the present commitment was on 2.5 billion for family planning. And further, the government now is committing another 5 billion to make sure that we have the required human resource. So we're going to employ another 5,000 midwives and nurses in the next 6 months. Together, all this represent approximately 12.2 billion in investment towards accelerating maternal and newborn survival. Never before this has happened in our country. And has there been very high-level presidential commitment? No. I mean, I'm the Minister for Health. I am the 23rd Minister for Health since independence. So I had to read the notes of the 23rd ministers, including the 4th President of the Republic of Kenya, Honorable the late Mwai Kibaki. And when I have read the notes, no president has made this kind of commitment other than President Ruto. And I want to commit also myself and my team, PS Mudoni, PS Oluga, the DG, and the whole team from the Family Planning Directorate and the other directors, that we commit in stewarding these resources to ensure that these resources translate into services, into results which they have been intended for, and maybe in another 6 months when we come back to a forum like this, we can see the numbers have gone down. Your Excellency, our First Lady, when a mother walks to a facility to deliver, she is not a patient. She goes to a facility to go and give us another life. And it's very unfortunate if that mother and the child dies. And that's why our healthcare workers, the products available, the facility infrastructure we are doing at our counties, as well enumerated by Governor Sakaja, is so important to our country and in saving mothers and newborn. Your Excellency, even within these interventions, we must continue to learn from where the system falls short. Through maternal and prenatal death surveillance and response, every maternal and newborn deaths must be reviewed to establish what happened, where the delay occurred, and what must be changed. A no blame and no shame culture is being advocated for. And this is to encourage honest learning, but we must review at the result in a very corrective action. By 2028, Your Excellency, we expect, as I conclude, this connected approach that our country is having today to produce reduction in maternal and newborn mortality, to give us a stronger emergency obstetric and newborn services, to grant us more reliable referral networks, and above all, to give us a very consistent standard of quality care across all the counties. Beyond 2028, Ewene must leave a permanent culture of readiness, of learning, and of accountability, so that every pregnancy is supported and every birth is given the best possible chance. Your Excellency, let me now thank you because you have sustained advocacy for health and the well-being of our women, the well-being of our newborns, and the well-being of the children and the families in our country, and how you have complemented government efforts and given Ewene an agenda of greater visibility. With you being here, with you being part of this discussion, and you have been doing it, this is a very privileged moment for us, that visibility, that momentum, and that purpose. We are proud to have you with us today in your capacity as an awareness champion, and we deeply appreciate the leadership and the commitment you continue to bring to this very important national cause. Colleagues and delegates, it's now my honor and duty and privilege to invite our First Lady of the Republic of Kenya, Her Excellency Mama Rachel Ruto, to deliver our keynote address this morning. Welcome, Mama wa Taifa.
Tumkaribishe mama taifa kwa makofi mazuri. Jameni, wapi shangwe na vigelegele za mama taifa? Tumpongeze kwa makofi, shangwe na ngemi. Wapi ngemi ya kina mama? Welcome, Your Excellency.
Thank you very much. We may be seated. Honorable Aden Duale, Cabinet Secretary, Ministry of Health, Mudomi Njuki, my apologies, Vice Chairperson, Council of Governors, and Governor of Tharaka Nithi County, Johnson Sakaja, Governor of Nairobi County, Governors present, Principal Secretaries present, County representatives, our development and implementing partners, healthcare professionals, and frontline health workers present. Ladies and gentlemen, good morning. Every mother remembers the sound of her baby's first cry. It is the most honest sound in the world. Relief, joy, and terror, all in one breath. That sound is what we are here to protect. I bring you warm greetings from our President, Dr. William Ruto, who in officially opening this summit yesterday, reaffirmed his commitment to strengthening healthcare and improving the well-being of every Kenyan. In healthcare, a promise is not measured by the words we speak. It is measured in lives. It is the mother who walks home with her newborn, the premature baby who defies the odds, the patient who finally gets care when they need it most, not when it's convenient for the system. It is therefore incredible to join you for this important conversation, from promise to practice, delivering quality health services for every Kenyan. I relate to it because I know that feeling of sitting outside a hospital room and waiting for news. I know the prayer that a mother makes when someone she loves is in the hands of a healthcare worker. And that is why when we talk about healthcare systems, I not only hear the language of policies and numbers, I hear the voices of families. In every facility we strengthen, every healthcare worker we support, every service we bring closer to our people brings us one step closer to the Kenya we want for our children. A policy becomes meaningful when a mother feels safe in a maternity ward. An investment becomes meaningful when a newborn survives. A healthcare worker becomes empowered when they have the tools to save a life. And a health system becomes successful when a Kenyan does not have to travel hundreds of kilometers to receive care. Ladies and gentlemen, in May this year, we launched the Every Woman, Every Newborn, Everywhere, Iwene Acceleration Plan, where we made a promise that no mother, no child should be lost to something preventable. So we must ask ourselves honestly, how do we turn that promise into a daily reality? The answer is not complicated. It takes leadership, investment, skilled healthcare workers, reliable equipment and supplies, referral systems that actually work when a life is on the line. And above all, it takes accountability across all stakeholders in the healthcare sector. The numbers tell us how urgent this is. Kenya's IWENE framework estimates maternal mortality at roughly 355 deaths per 100,000 lives births, with neonatal mortality around 21 per 1,000. But I want us to remember, those are not just numbers. Behind every single one is a mother, a newborn, a family that carries that loss forever, and a community that feels it too. So we cannot be satisfied with progress. We must insist on impact. As a goodwill ambassador for newborn screening in Kenya, I'm encouraged by what the Ministry of Health has already committed to. Under the IWENE Acceleration Plan 2026-2028, we are expanding maternal health care coverage through the Social Health Authority, investing in essential maternal newborn commodities, family planning supplies, recruiting and redeploying thousands more nurses and midwives. Today, we have heard what happens when promise becomes practice. We have heard about Pumwani Hospital that has had near zero maternal deaths. This has been through strengthened systems and relentless focus on quality care. We have heard about a maternity team in Kisii that went a full month without losing a mother. For that team, that is not statistic. That is a month of families going home together. And we will hear about Mwai Kibaki Referral Hospital, where more than 15,000 people have been reached in their communities for screening. 15,000 opportunities to detect disease before it becomes a tragedy. These stories tell us something important. The Kenya we want is not an impossible Kenya. We have already seen glimpses of it. Our task now is to make those glimpses the standard. Ladies and gentlemen, let us build a Kenya where a mother does not have to be wealthy to receive quality care, where a newborn's chance of survival is not determined by the county in which they are born, where a health worker is not sent into a crisis without the tools to respond, where a family does not have to choose between seeking treatment and putting food on the table, where quality healthcare is not something we promise our people, but something they experience. That is the Kenya we must build. That is what moving from promise to practice means, and that is the responsibility we carry together. Let us not be the generation that simply made promises, but be the generation that kept them. Okoa mama, okoa mtoto. Save the mother, save the child. Thank you. May God bless you all. May God bless our great nation of Kenya. Thank you very much. Thank you for the great work. I wouldn't want to say more than this, Waziri, because this issue of mothers touches all of us. Let me stop there. God bless you.
Thank you so much, Your Excellency. With due diligence, I request Your Excellency to remain on stage. Taomba mama taifa kwa heshima, wengine tuketi tafadhali. Kwaya zetu, chukua nafasi zetu kwa wimbo wa taifa. Mama taifa, asante sana na tunakushukuru. Wewe ni chombo cha amani na kila wakati unatupa bega lako ili tuweze kuja kukuomba. Nitamuomba waziri wetu, chukua nafasi kwenye jukwaa, PSS wetu, Director General, governors wetu na wajumbe wale wako, ili tupate picha moja na mama taifa. Niombe mama taifa. Shukran sana kwa waziri wetu, PSS wetu, Director General na wale wote wanaohusika. Magavana wetu, shukran kwa kuja kuidhinisha upendo wenu kwa masuala ya afya na hasa kushinda na mama. Tunasema shukran za dhati. Picha ya mwisho mama taifa ni every woman, every newborn, everywhere. Tafadhali wale wako tujiunge mbele, tujiunge na hiyo picha. Yeah, the rest of us can take our seat apart from waziri and his team. Magavana na wajumbe wanaweza chukua nafasi zao ili timu hii inayofanya kazi karibu sana na mama waweze kupata picha hiyo. Let's take our position. If you can balance. Wengine wapita nyuma, tuje upande wa juu. Every woman, every newborn, everywhere. Ni furaha yangu kuona kwamba siku ya leo tumeanza siku na mama. Siku njema huonekana lini? Na ni kweli tumeiona siku njema. Tumpongeze mama kwa makofi mazuri. Shukran. Nitaomba sisi tuondoke, tumwache mama jukwani ili tuweze kumaliza. Na kabla ya kuondoka nitaomba waziri asalie, waziri na PSS, waziri and the two PSS, niletewe token of appreciation for mama. The token of appreciation. Ni tunu tu ya shukurani kwa mama ili atakaporudi nyumbani aweze kujua kwamba Wizara ya Afya inamenzi na tuna kila sababu ya kusema asanti mama kwa kuwa kielelezo chema. When we have a caring mother like you, we'll go far. Let's appreciate that token of appreciation that has been received na mama taifa. Shukran. Shukran kwa kupokea tunu yetu. Mwenyezi Mungu akubariki na kila uombalo kwa imani upate kweli. Nitaomba waziri na PSS waweze kuondoka, mama atasalia. Niombe sote tusimame. Walio na kofia ambazo si rasmi na kofia za chepeo tuweze kuzitoa. Tutaongozwa na wimbo wa taifa na kwaya yetu ya SHA na kwaya yetu ya KEMSA. Wimbo wa taifa. Tumefika mwisho wa sherehe yetu asubuhi ya leo. Tumpongeze mama taifa anapoondoka. Ni furaha yangu na niombe wananchi tutasalia ndani. Niliwaambia mama akishaondoka baba anaingia. Kwa hivyo tutulie wakati wowote kuanzia sasa. Mheshimiwa Rais atakuwa tuketi tafadhali, tuketi. Asanteni sana. Kuwapasulia tu mbarika ni kwamba wakati wowote kuanzia sasa Mheshimiwa Rais na naibu wa rais wataingia. Kwa hivyo tuwe watulivu. We'll be receiving the president anytime from now. So choirs tuendelee kupata burudani.
Kenya, hatutaki matata Kenya, wenzangu, wenzangu, Kenya kipenzi chetu. hatutaiacha milele. Kenya kipenzi chetu, nchi yenye upendo, hatutaacha Kenya daima na milele. Kenya kipenzi chetu. Nitaitukuza, nitailinda maishani mwangu. Fika Mombasa, wito wa bahari, ogelea maji, jua tamu kuota. Fika Mombasa, wito wa bahari, ogelea maji, jua tamu kuota. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Na wananchi wote ni sawa tu, wapenda ugali na sukuma wiki. Na wananchi wote ni sawa tu, wapenda ugali na sukuma wiki. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu. Nitaitukuza, nitailinda maishani mwangu.
Haya, nafahamishwa sasa tunatembea katika eneo mbalimbali za Jamhuri yetu ya Kenya. Mwalimu ananiambia kwamba tunaanzia kule upande wa pwani. Tupate wimbo wa Kigiriama. Nikipata mdadisi wangu ananiambia kwamba ni wimbo ambao umechezwa na Mjerumani. Lakini kwa leo kwa sababu Kijerumani kinatuchenga kidogo, watatuchezea kwa Kigiriama. Kisha baadaye mwalimu ukiona ni safi utupeleke upande wa Nyanza. Twende coast.
Mungu wanifujira noni, kariko secha rochose, ingini chakugenja.
And members of the Health Committee of both Houses of Parliament, partners, donors, ladies and
gentlemen. So allow me first just to set the stage for our panelists by saying the following, that His Excellency the President yesterday, in the morning and in the evening in the town hall, set out the direction of our national health reforms and the progress that we have made together as national government and county governments working in concert. My task during this session is much narrower than the President's overview that he gave us yesterday. I have been asked to focus on execution, on what must happen for the reforms in this sector to deliver consistently to the people of Kenya. And for that purpose, I invite you to consider a simple delivery equation, which is the right health workers, the equipment, which have the right products and technologies, and also delivery of the right services at the right time. Effective implementation requires a coordinated approach. I don't want to overemphasize the need for coordination. And I want to salute our brothers and sisters in the Council of Governors. Governor Abdullahi, the chairperson, and your team, we are very, very blessed to have this cohort among the Council of Governors. Between you and your predecessor, Governor Waigoro, the former chairperson, you have given President William Ruto and those of us in this administration support and unequivocal cooperation that could not have been possible without the right leadership at the Council of Governors. Let us appreciate our governors. So that coordination, I've been blessed to be part of that delivery by virtue of my work as chair of IBEC, which is the Intergovernmental Budget and Economic Council of the Republic of Kenya. And I'm again, in that role, I have had the privilege of working with the colleagues, ministers, members of the cabinet, PSAs in the various sectors, but also I have had the privilege of a very supportive Council of Governors who have made my work very easy. Again, let us applaud each one of us. So this coordination and cooperation has been very, very present. And the need for us to continue in that manner into the future is because if one part of the equation fails, then the patient will feel that failure immediately. A trained healthcare worker without medicine cannot treat. Modern equipment without personnel or maintenance cannot provide health services. Financing cannot improve health if the facility is not ready to deliver care. Therefore, colleagues, brothers and sisters, the health system performance is therefore not just the total sum of individual programs. It is the reliability of the complete patient journey. We need one healthcare system with the citizens at the center. I'll be speaking to this a little more in my summary because we need this health system must deliver to the people of Kenya. If we do everything else and the system is not serving the people, we will not have achieved the objective. County governments are central to the success of this reform agenda through the implementation of the universal health coverage, strengthening primary health care, because they control the facilities in this space, the health facilities, and they control the entire frontline implementation and service delivery, the CHPs and also all the facilities up to level 5. Ladies and gentlemen, distinguished guests, that journey should begin at the household and at the primary healthcare facility before illness becomes severe and expensive. The primary healthcare fund, as we were told by His Excellency the President yesterday, has received 27 billion shillings, has paid out 23 billion shillings to more than 9,300 level 2 and level 3 facilities. Unprecedented. Every time I travel out of town, every time I accompany the President out of town, they are telling us that the amount of funding that dispensaries, level 2, level 3, facilities are receiving has never been received. I went to a dispensary somewhere in Kericho, in Sigoit Soin, and the governor there, Eric Mutai, was with me. And the dispensary told us this week we have received 1.4 million shillings from SHA this week. And they say in the past we never even received anything above 100,000, 50,000 at most under NHIF. So that's where we are. And this is money, as we are going to see, that is going to be retained to improve service delivery in that dispensary. It's not going to be sent elsewhere. The financing, this financing has supported more than 20 million outpatient visits by 15 million Kenyans. We have also increased primary care networks from 2 in 2022 to 278 hubs spread across the country. The fund is functioning. The next question is whether every shilling improves the facility's readiness and the patient's outcome. We must measure medicine availability, waiting times, early diagnosis, maternal and child health outcomes, and completed referrals. Primary health care must become the dependable front door of our health system, close to the people, capable of resolving most health needs, and connected to higher levels of care when timely referral is necessary. In that connection, it is important to note that we are improving, or we have improved how we respond to emergencies through the SHA 922 Lifeline and National Ambulance Dispatch Center. Kenya now has one national medical emergency number. One free call to this number connects a citizen to a trained dispatcher, an available ambulance, an appropriate facility and financing required for evacuation and the first 24 hours of emergency treatment. We must now make 922 dependable in every county so that we measure performance through calls that are timely answered, ambulance response that is timely so that it can save lives, appropriate referrals, and lives saved. In an emergency, geography and household income must not determine who survives. The same delivery discipline must guide the National Equipment Service Program, NESP. NESP is strengthening diagnostic imaging, theater, renal, laboratory, and other specialized services in county health facilities. His Excellency, the President, gave us the statistics yesterday, what kind of equipment, the value, and the program is ongoing, and it's across the country. Again, unprecedented. But equipment delivery is not the same as a service delivered. Our concern must be whether the equipment is functioning, whether trained personnel and consumables are available, and whether patients are receiving timely services. More than 500,000 surgical procedures and over 50,000 cancer care services have been supported through SHIF, the Social Health Insurance Fund, and Emergency Chronic and Critical Illnesses Fund, ECCIF. We must now build complete pathways in which screening leads to early diagnosis. Diagnosis leads to treatment, and treatment includes appropriate follow-up and rehabilitation or for optimum health outcomes. Our ambition is not to own more machines. It is to shorten the distance, the time, and cost between a Kenyan and the care that can save their life. None of this is possible without health workers. Since 2022, Again, the national government, in collaboration with the county governments, we have deployed 24,000 healthcare interns across all 47 counties. We've sponsored 262 medical registrars for specialist training, and we have committed now to recruit additional 5,000 nurses and midwives. Internship must remain. And this workforce is now supporting the 107,000 CHPs that are on the front line. So you can see already the progress that we are covering on the issue of personnel and healthcare workers. Internship must remain predictable and properly supervised. But we must look beyond placement. National and county government needs one workforce plan connecting training, internship, recruitment, equitable deployment, career development, and retention. We must also train for the health system we are building, not the one we are leaving behind. That means stronger competencies for the future areas of healthcare service delivery, which include primary health care, oncology, surgery, anesthesia, emergency medicine, critical care, biomedical engineering, and digital health. A health system cannot perform consistently when its workforce is managed through periodic emergencies. Our health workers must be planned and supported as a strategic national asset. I repeat, again, commending the fantastic work under CS Duale and our team in health, the COG, through the chair and the health committee and the entire leadership. We must continue to make sure there is stability within our healthcare workers. We cannot have a useful and progressive delivery system if our healthcare workers are disrupted from work. So we must build on this progress, and we have no excuse, we have no reason, we have no justification to allow disruption of healthcare service delivery. I must commend also the leadership of the healthcare worker unions. They have been very reasonable, and you have supported both county governments and the national government to find win-win situations to avoid disruption of service delivery. For the avoidance of doubt, we, the government of Kenya, national government and county governments, treat you, our healthcare service providers, as a strategic national asset. Brothers and sisters, ladies and gentlemen, the second condition for reliable delivery is commodity security. KEMSA's order fill rate, as we heard yesterday, has increased from 40% to 91%. And we have supported as national government KEMSA with 1.5 billion shillings directly, and also provided support for them to access a line of credit to the tune of 10 billion shillings. The next stage is to build an end-to-end supply chain that anticipates shortages before facilities run out. National procurement, county obligations, distribution and facility inventory must become one visible and accountable system. I was there when KEMSA and DHA were updating the president on where we are. And I think where we need to fine-tune now is the integration of the digitization process in KEMSA with the Digital Health Agency medical health data, so that it's one seamless. You cannot have a digitized supply chain data that is separated from mainstream healthcare data. So the two are interlinked. So we need the two systems to speak to each other. And the supply chain and commodity supply chain data to be part of the whole under DHA. In the longer term, Kenya must manufacture more of the medicines, diagnostic medical devices, and offer products that we consume. Local manufacturing will secure our supplies, create skilled jobs, support innovation, and convert health expenditure into domestic economic opportunity. The reforms are in place and the investments are being made. What is now required is disciplined coordination across national government, county governments, agencies of government, providers, training institutions, partners, including implementing partners. We should leave this session today with a compact set of performance measures: facility readiness, equipment uptime, medicine availability, workforce coverage, waiting times, referral completion, patient safety, and health outcomes. Digitization must be the performance enabler that connects the patient's journey, gives us real-time visibility of health workforce, commodities, equipment, and referral pathways that enable timely correction and accountability wherever the system is off track. These measures should be visible by both the facilities and county governments. Strong performance should be recognized and shared. Persistent underperformance should trigger support, corrective action, and accountability. Our objective is straightforward: a health system that works the first time, works in every county, and works for every Kenyan. That is how we will move from policy pronouncement to programs, to performance, from investment to value, and from the promise of reform to reliable healthcare delivery. Thank you very much. I will be back with a summary, which should not take more than 10 minutes. I just thought I needed to make a pitch for all the issues and for the record of this conference to read a speech. Otherwise, when I come back, I will not bore you with reading any speech. Thank you very much.
Thank you very much, Your Excellency. Thank you very much. We may be seated. Your Excellency, allow me to practice. You know, you want us to be comprehensively competent. So before I call the panel, I just want to ask the crowd, Deputy President wetu ni fire si fire? Ni noma si noma? Summit ni fire si fire? Ni noma si noma? Your Excellency, you know I have to practice for a possible career. Your Excellency, at this juncture, with your permission and that of the Honorable Cabinet Secretary, allow me to call our panelists. I'll begin with the Vice Chair of the Council of Governors, His Excellency Muthomi Njuki, who is also the Governor of Tharaka Nithi. Please join us in this high-level panel discussion on HRH, HPT, and service delivery. We'll also call on stage the Chair of the Committee of Health at the National Assembly, Honorable Dr. James Nyikal. Please join us. I'm trying to look for Dr. James Nyikal. I'll also call on stage the CEO of the Kenya Medical Supply Agency, Dr. Warko Ejesa. Please join us on stage. We have the chairman of the Healthcare Federation, Kenya Healthcare Federation, Dr. Gakombe. Please join us on stage. We also have representative of the UN agency, Dr. Neema Kimambo, who is the country representative for WHO. Please join us on stage. Yes, I can see Honorable Dr. Nyikal. Yes, and I will also call the CEO of one of our hospitals, Dr. Richard Lesiampe. Please join us on stage. And for the National Assembly, before we have Honorable Nyikal, who was around, I think we have a member of the Health Committee, Honorable Dr. Robert Bukose. Please, you can stand in for Dr. Nyikal. And Your Excellency, as the panel settles in the questions, just as a prelude to the discussion on HRH, we have a State Department established for the first time in this government on professional standards. So allow me to call Madam Mary Mudhoni just for a 1 minute discussion on what this State Department has been able to do. Thank you.
Thank you very much, Daktari, Your Excellency. Karibu sana for our summit. Mine is just going to be a wrap-up of what generally we look at when we talk about HRH, or Human Resources for Health. And one of the key areas, and I know His Excellency Governor is going to talk about, is the requirement to deliver the right numbers. That is why the government is continually employing. Just the other day, we have been able to transition our UHC staff from contract to permanent and pensionable, and the counties every other time are employing to ensure that our facilities have the requisite numbers to treat the people of Kenya. Again, we are also talking about delivery of the right skills. From the State Department of Public Health, I keep telling the healthcare workers, niko na pesa ya kukupeleka shule. You only need to apply so that we can take you for postgraduate training. So do not just stay with your 1 degree. We can go and take you for specialized skills so that when you go back to your facility, you can add more value. We are talking about equitable distribution again. Just before we came in, we were talking about what we are going to do to get the needs assessment for the whole country, so that we are very clear on who we require in every county and every corner, and in all facilities. As we also send you for postgraduate training, we will be very keen to know how many obs-gynas are in Tharaka Nithi County versus the ones in Mombasa County as equivalent to the population. Then the fourth thing that we are going to listen to is the delivery of decent work and productivity. Management must address workforce challenges such as unemployment of trained professionals, issues to do with faculty gaps, issues to do with attrition, migration. And I am sure these are gaps that we have continually tried to address as we look into the structural limits, and that must be navigated while protecting the worker rights, safety, and also the well-being of our healthcare workers. And finally, deliver on the data-driven accountability. The whole of this summit, we've been talking about data, because data does not lie. And when you have the right data, you're able to also plan for the future. So Kenya has demonstrated a very growing capacity for evidence-based planning, ranking 3rd in Africa, and also 6th globally in national healthcare workforce accounts, reporting with 92% data availability. So with those few remarks, I take back the mic for the panel.
Thank you, Madam PS. And now we go straight in, which will be like a quick fire of just 30 minutes. And we begin with Your Excellency, Governor. The Constitution decentralized service delivery. and established counties as the responsible level of government when it comes to management of health. Looking at where we have come from and the reforms that we have established, how do we enable coordination that ensures that national government, county governments strengthens service delivery at that level? And as you answer that question, you may also talk broadly about county public service boards and the role that they can play in strengthening health workforce component as a part of health systems. Excellency, please proceed.
Thank you very much, PS Oluga. Of all the resources that we have put together as a government of Kenya to bring the health sector where we are, the most critical one is human resource, which sometimes we normally put at the bottom of the pyramid because it is a moving target most of the times as compared to all the other resources. It is possible for you to be able to tell how many drugs you've been able to move from KEMSA. You're able to tell how many equipments. But the management of human resource is so delicate because we are dealing with human beings who sometimes have responsibilities beyond the work that they're in. I say that because since devolution, which was supposed to bring services closer to the people, we've seen improved number, or rather we have seen number of health workers increasing in the counties as compared to before devolution. Not just increasing in number, but also in terms of quality and terms of representation. And to give you a perspective on that, remote counties in Kenya before hardly used to retain very specialized health workers, especially the ones in the cadre of the ones we normally call the specialized consultants, where you find a remote county like Turkana used to have only 2 consultants. And those ones would hardly be permanently there because they have calls, maybe in the hospitals in Nairobi over the weekends, so they are in Turkana Monday and Tuesday, Wednesday they move. But since Turkana, I'm just giving Turkana as an example because we have the data that is amazing. Since we are given the responsibility to recruit, retain, motivate, and ensure that these specialists are meant for the Turkana people, they have seen the numbers rise from around 2 to over 20 specialists who are highly motivated, who are retained, and the Turkana people get value for their money. It is the same case across all the counties. Because when you manage your health workers, it is possible for you not just to monitor, but also have a responsibility as a team without being coordinated from somewhere else on your duties to be able to deliver. Secondly, we have seen increase the number of health workers in all counties since devolution. The number of nurses have increased, the number of clinic officers, the number of MOs. It is not just because of coordination, but because of deliberate effort by the leadership of the counties to fill in the gaps and also to adhere to WHO standards of the 5-kilometer radius of a health facility. And because of that, our patients are traveling shorter distances now to receive that care. Not just only to receive the care in the facilities, but for specialized, well-motivated healthcare workers who would usually respond to their needs. Do we have a challenge? Of course we do. One of the major challenges in that space is always having inadequate staff. Not because you don't need them, but because the capacity to hire them may be limited by the resources available. And even when the resources are available, we are limited by the established structure of the workforce. because we have a formula that does not allow you to have over 35% of your resources going to personal emoluments. So if you want to employ more staff in health sector and you need them and your physical space cannot allow it, you're only left to distributing the ones you have very thinly because you cannot ask for more resources unless you generate. Thanks to what is happening now in the space of health, since we had the reforms and the 4 laws that we passed, we have more resources now being generated through reimbursement of SHA, and with the facility improvement fund, we now have more resources that are available. But is it possible to direct those resources to employment? At the moment, I don't think the structure allows that. We plow that back to improve the facility. Does the facility improvement include employment? That is a good question we should be asking ourselves on the way forward, because that is also a need.
Thank you, Excellency Governor. I know time is limited, but I wanted you to comment on the intersection with the county public service boards. There are a number of counties that occasionally we find the county public service boards needs a bit of strengthening. The Constitution talks about the advisory role of Public Service Commission, but then how do we engage so that then service delivery is not interrupted?
The County Public Service Board have played a very critical role in recruitment, in ensuring that we don't just recruit, but to have the right staff with the right skills and also being placed in the right places. And you are aware that even in the coordination that we have with the national government, the MOH, on the staff that we have shared responsibility, like the UHC, the recruitment was by the County Public Service Board, even though the payroll has been domiciled in MOH. Without the County Public Service Board playing the right role, we would be having these workers being somewhere in between without direct responsibility and supervision. Yes, it is true that we need to kit, or rather to continuously build our capacity for Public Service Board, because they may not currently be at the same level of Public Service Commission. But a lot of work has gone into capacity building, and we are seeing proper interpretation of policies from the MOH and also in Salaries and Remuneration Commission, and also from Public Service Board, that have made the counties also be units of higher standards of professional recruitment in the workforce.
Thank you, Excellency. A round of applause for Excellency Governor. Now, on the same note of HRH, before we move to service delivery, we work with WHO at the Ministry of Health, and there are 2 key documents where the leadership led by Honorable Cabinet Secretary Aden Duale has been pushing us that we must have a health professionals policy. And this relates directly to how we galvanize the management of health workers from training. I know that WHO has had some input to the Ministry of Health, and as you mentioned, the role of WHO in intersecting with national governments that are member states of WHO in establishing policies for health professionals or even health workers. You may also comment on the Health and Care Compact, which is also another tool that involves a framework for enabling countries to clean up, let me use the word, clean up the space of health workers, because it's been a big challenge, including the code of practice for international recruitment of healthcare workers, just so that we wrap up that session on the health workforce.
Thank you very much, PS and Excellencies. I'll stand on existing protocol. So WHO has been working with the Ministry of Health on health workforce with support from the UK government. And I just want to highlight several tools that have been very useful. WHO has a tool called Health Labor Market Analysis, which enables the country to look at the different cadres they have, where they're placed, and look at the needs. And this health labor market analysis helps to look at the training, the production, and all the different cadres that you have and the needs of the country to enable the country to be able to plan with evidence for their health workforce. Another very important tool is the National Health Workforce Accounts, which helps the country to really come up with data of all the health workers they have. And prior to using the National Health Workforce Accounts, maybe we had numbers that were just at national level, but now we have detailed data that even counties, all the 47 counties, are able to see all the health workers that they have and where they are placed. And this is important because you're able to see the gaps and you're able to see where it is most important and where the gaps are, so that you place, as you recruit, that you place them in the correct places. And this was what PS Muthoni alluded to, that Kenya was ranked third in the region and sixth in the world in terms of data. Another important tool is the workload indicator staffing need. This helps managers to be able to look at the load that the health facility is covering, what types of patients are coming in, and this then guides them to be able to plan appropriately based on the need of health workers. So we have been able to work with the ministry on this, and for the first time, the ministry has now come up with a health workforce policy and also a health workforce strategic investment plan. And at county level, about 130 managers, HR managers have been trained on this workload indicator staffing need, which will enable us to plan better in ensuring that we put health workers where they are most needed. And this brings in now the African Charter, which aims to ensure that we train, that we deploy, and that we retain health workers where they are needed, and to be efficient in our placement of health workers, because sometimes you can have the numbers, but you may have huge numbers, maybe in Nairobi, for example, and there's duplication, and you have other places which are more remote, which are lacking the services. This health labor market analysis also informs what PS Oluga has alluded to on the International Code of Migration of health workers. You are able to see what is your output, and are you able, countries are labeled according to their production, according to the staffing that they have, to see whether they can export health workers. Now, if you export health workers, what has been happening previously was in countries with good training, quality, you would have health workers being taken by developed countries, but the country that has been producing those health workers is not gaining anything. So at WHO, we work with countries to have, as they come into agreement with developing nations, as they are taking staff, that you have an organized migration, but you also get good contracts for those who are going, but also what comes back to the country, because the country has invested in training these people. So if they are going abroad, if you're producing more than you can use, but what is the country gaining? So WHO has been working with several countries, as well as, I know, Kenya, Ghana, Nigeria, and others in terms of helping countries to negotiate for this organized migration where needed. Thank you.
Thank you, Dr. Neema. Your Excellency, if you allow me, that the issue about the co-investment that WHO talks about is important for Kenya, because I know this is also one of the key agenda of our government. And I just wanted to ask for a roving mic, Your Excellency, just so that we get the numbers from KMTC in terms of nurses and those who are going abroad. so that then we can look at how to engage in this co-investment decision. And this is important for your leadership. So the CEO of KMTC, just a 1 minute comment on those numbers and how they have improved. Please, roving Mike, CEO of KMTC is right here.
Thank you so much, Your Excellency. My name is Dr. Kelly Oluoch, CEO of Kenya Medical Training College. Your Excellency, in 2022, we were graduating 15,000 students. In 2025, Your Excellency, we graduated 22,776 students. Your Excellency, that is an increment of 43%. Your Excellency, this year, we are going to graduate 25,000 students. Your Excellency, one of the efforts that we need and very critical for us is responsible labor mobility. Your Excellency, as an institution, Kenya Medical Training College has created foreign language curricula in German, French, and Arabic, and now Amharic, to support labor migration. What Madam Nema is talking about is critical for Kenya Medical Training College because we are the largest producer of human resources for health in this country and sub-Saharan Africa. So we will want to engage to make sure that we're able to ensure that those we graduate are able to get gainful employment, not only locally, but internationally. Thank you, Your Excellency.
Thank you, Your Excellency. That just looks at some of the gains, and also I hope that our media, you recorded, we are here for reforms that have been delivered. You recorded that Kenya is the 3rd in the world as far as health workforce data is concerned. I mean, the 3rd in the region and the 6th in the world. I'll move very quickly to service delivery. And here I will be asking from the private sector, Dr. Gakombe is here. 46% of the facilities now are private sector. The government has established the enabling frameworks for financing. How do we strengthen performance of service delivery at the private hospital level?
Thank you, PS Oluga, and allow me also to ride on existing protocols. It's true that the private sector is a key provider of care in the country. And because we must achieve access, achieve quality, and be efficient, one of the key things to achieve that, or one of the most enabling features or developments, is digitization. Because digitization allows all of us to keep track of what is happening across the entire country. And it allows us to tie all the facilities together, track referrals, and track outcomes so that we can be outcome-based rather than purely focusing on the infrastructure available. And I want to take us back to a point when we had COVID. During COVID, the Ministry of Health scrambled to find ICU and critical care facilities. Today, that's not a problem anymore because SHA and the Medical Council and the ministry have live data on where that infrastructure is, whether it's occupied, and what is happening to the patients who are admitted in those facilities. Once we link up with the registration service so that we can record deaths and births on a live basis, we'll even go a step further so that outcomes can easily be tracked. So there's a lot that has happened, but one of the most critical is digitization, and the second one is the financing reforms. It's true we had NHIF, it had its challenges, we have SHA, and we've worked very hard to address some of the teething challenges SHA has. But for we in the private sector, payment comes from the patient, and many of them don't have money to pay. So having SHA pay their bills, having private insurance pay their bills, having employers pay their bills, enables more private sector service providers to thrive and grow. And for some of our patients, like dialysis, the only insurer and the only payer for the whole country is SHA. I do not know many places where there is anyone else paying for dialysis other than SHA, and the amount that is being paid is usually what we charge, because many of us are not charging anything beyond the SHA price. So we are keeping people who have end-stage renal failure alive through A, collecting money and channeling through SHA, and B, allowing private providers and paneling them as providers of service so that Kenyans have a lot more access.
Just in 1 minute, a very important thing. So His Excellency, the Deputy President, has just emphasized what the President mentioned about primary healthcare fund. Counties are here. They have made a lot of investment at that level, level 2, level 3, PHC, 27 billion, 23 billion paid. How do we shift the mindset of the private sector to invest in specialized services? 70% of PHC covered by government. We still do very less transplants. We still do very less cardiac surgeries. How do we shift the mindset of private sector that it is no longer very needed to just open up a clinic, pay very high rent, and Homa that the government has already invested at the village level? Just in 1 minute.
Our biggest job is to fill whatever gaps are left after the counties and the national government have provided service. So what you're anticipating is already happening. Many of our facilities, including the one I lead, are moving into more specialized care, renal, cancer, heart transplantation. And one of the key areas we are investing in, if you recall, that we've had a lot of traffic going out of country for treatment. And it's now policy that Kenyans should be treated here, close to home, near their relatives. That's a policy. And there is the money to finance it. So we are investing a lot more in upgrading care. I myself have brought the first robot for knee surgery in East and Central Africa, and we've already operated on 13 patients who would ordinarily have gone out of the country. And there are a couple more robots that have come in. So as KU does CyberKnife, Aga Khan is doing something else that is also quite specialized. We are doing something else which is quite specialized. And we'll be in Ethiopia on Thursday to tell them what it is that we can provide to them.
Thank you.
We are regional.
Thank you so much. This is very important. And I'll bring in KNH. Yesterday you spoke in the town hall, you mentioned the establishment of the theater. So today, just tell us the outcome, the quality, and perhaps you bring in the technology, because KNH, you mentioned that is digitized for the first time, of course, with the support of DHA. So just tell us, how has that improved two things? One, experiences of patients, and number two, outcomes.
Thank you very much, Dr. Oluga. Let me recognize the presence of His Excellency, the Deputy President. Kenyatta National Hospital is the second largest hospital in Africa. In fact, we still remember and say that it is the largest hospital south of the Sahara and north of the Limpopo River. And it has existed for 125 years. It has provided services for 125 years, to this nation and also to the globe. When it comes to issues of specialized services, Kenyatta National Hospital with the University of Nairobi have not less than 500 specialists, in almost every disease burden. 500. And we actually focus on specialized treatment. We are actually the apex of the referral system of our nation, and we are also the apex of research in medical spaces. So what we are saying is that we have several reforms that have taken place in the last 4 years. And one of them is digitization, automation, and embracing technology. And we are automating and digitizing, the patient journey at Kenyatta National Hospital. From registration, triage, the imaging, to admission, theaters, pharmacy, up to discharge. And this has huge, clinical outcomes, and in fact has a great patient experience in the sense that patients will be seen, on time. There will be no operational delays. There will be less, delays in payments, for example, in terms of SHA registration, in terms of SHA reimbursements, in terms of SHA claims. And therefore, that is one great thing that has taken place, at KNH. We are not yet there, but we believe that in the next 1 or 2 months, we will actually conclude not only on the clinical digitization, but also in the back office digitization, where we actually bring on board an ERP system to manage the procurement, to manage finance, and also manage HR. So I can also say that the last several years, we have managed to acquire, specialized, and modern equipment through the National Equipment Service Program. What in particular, when it comes to cancer, we now have 2 LINAC machines. It has never happened at KNH for the last, I think, the 125 years. We are also going to get another LINAC machine probably by end of September. We'll have 3 LINAC machines, high-level machines. These machines will definitely, create, great clinical outcomes for our patients. All patients who will come to Kenyatta National Hospital suffering from cancer, requiring cancer treatment, will indeed, benefit from this. And these clinical outcomes, will definitely demonstrate that our health system is working. We are also, in the sense of clinical outcomes, we have also acquired, modern ultrasound machines. We used to have 2. Today we are having 6 through the same National Equipment Service Program. This will also improve on the clinical outcomes when it comes to imaging. It will give us images, very fast images. The reports will be done very fast, and diagnosis will actually be done, additions made very, very fast. As I conclude, when it comes to issues of emergencies, I want to say that, through the ESCCF, Kenyatta National Hospital receives almost all the patients who go through difficulties in Nairobi and in this country. All disasters are managed at Kenyatta National Hospital. All motor vehicle accidents, in particular, probably also managed at Kenyatta National Hospital. All fires that take place in our country, in most instances, they are managed at Kenyatta National Hospital. With the ECCIF, those patients now can access, free medication the first 24 hours, and from there we move them to SHIF. And this actually gives us, great outcomes in terms of management of our patients. As I conclude, we are the only national hospital or public referral hospital which has got golf carts. Our patients who cannot walk, our patients who are old and elderly, our patients who are, pregnant mothers, when they land at our Kenyatta National Hospital parking space, when they land there is a golf cart waiting for them. We carry them to navigate the whole hospital. From the bus stage, they are taken to the cancer center in those golf carts. They are moved from the cancer center to the diabetic spaces. They are also taken to the bus stage, back for them to travel back to their homes. There is no any other hospital globally, I think, in a public sector.
Thank you so much. A round of applause for Dr. Lesiampe. We now have golf carts. I think he must be responding to experiences of patients so that we make it easier. I will bring in the National Assembly. Your Excellency, Deputy President, as you are already very well aware, the government has pushed for 4 pieces of legislation. The only piece of legislation that relates to service delivery, quality of care bill, quality of care and patient safety bill is still in the National Assembly. We've done Primary Healthcare Act, we've done the Digital Health Act, we've done the Facility Improvement Financing Act, and of course we've done the Social Health Insurance Act. Now, at the level of interaction of all this equipment, of the medicine, of the healthcare worker bringing his knowledge and expertise to ensure that the patient goes home with their problem solved, there's something we call the Quality of Care and Patient Safety Bill. And this is the last piece of legislation. And I wanted, as we discuss service delivery, that Parliament could comment on their role and how they see this panning out. Thank you, Chair, and welcome for this plenary.
Thank you very much, acknowledging His Excellency, the Deputy President. Legislation is key in all these things that you have said. Eventually, if they have to be enforced, there's need for legislation. And as you have indicated, the 4 acts, particularly Primary Healthcare Act and the FIF Act, has had tremendous effect, and then shift on top of it. So now we have the quality of care bill and quality of care and patient safety. Basically, what this bill is attempting to do or is planning to do, and which is supported, is actually to split the regulation of personnel, the professionals, from the regulation facilities. I think that is the summary of it. And this is important because there's a lot of overlay that come together. And when you get that, then you can now say we regulate the personnel, the professional like this, and the facilities are regulated. And you know, there are a lot of issues that will come with the regulation facilities, how they are accredited, how they are empaneled, and so on. So that is important. This has actually passed through the National Assembly and is actually going to the Senate, and we are looking forward to it. What I know and the challenge that we'll face, and I think the minister is up to it, it is going to affect very many other acts, laws that are in place. And when we are looking at it, we looked at this, and I know very many professionals will come up, and the issues will have to be sorted out, and we must put a transition process which is very well worked out so that it doesn't bring clashes. But there's also one else, probably. We already have an authority act. Again, that is important if you are going to talk about we have the drug authority bill that is also in Parliament. It has passed through the National Assembly, is in the Senate, because that is going to be key if you are going to go into drug manufacturing. There is a need of a level that will need to, and that will be important. Again, that will be splitting the regulations of HPTs, health products and technologies, from the regulation of professionals. And I think all these are important. So many things that we are looking at, Parliament is key. Another element we probably didn't ask is the area of appropriation. And I must really praise the government and the ministry, because where we have actually appropriated, we can see the results. And so with the National Assembly, in terms of legislation and also in terms of appropriation, it's extremely important. That's all I can say for now.
Thank you so much. You know, Honorable Chair is a very senior health professional in this country. Please, let's clap for him for those very good comments. We want to move to the last session of health products and technology. We've heard a lot about KEMSA and the last mile delivery, and your clients are here today. Please don't dwell on the debt. Just dwell on how you can get the facilities to get medicine. And this thing, Waziri mentioned it in his remarks. How do we cure the disease of Hakuna Dawa Hospitali? And because the governors are here, and as you make very few comments, I will also be calling the chair of the Committee of Health just to wrap up on that bit about how do we ensure that last mile delivery before I bring back the CS to proceed with the program. So, Honorable Dr. Edjesa Wako, the floor is yours.
Thank you, PS. I recognize the presence of His Excellency, the Deputy President, and the protocols as established. Thank you. I think this is a very important discussion that we should have. Those of us who have done public health practice, There is the adage that goes, no commodities, no program. So whatever we do, if we don't have the final products, then we are not talking about health. So we take cognizance of that in KEMSA, and we said, as part of universal health coverage, what can we do differently to cure this Hakuna Dawa syndrome in the head? So we sat, like 3 years ago, we sat and discussed and said, what do we need to hit? What are the high impact interventions? In life and in programs, you can do so many things, but what are the high impact interventions that we can hit to score, to move from 40s to 90s? Now, then we sat and said, KEMSA is not a traditional supplier that pushes boxes to facilities. Let us engage the counties, our customers, the facilities, and ask them what really matters to them. What do they require to give optimal services, and what do they need? What are the needs? Because we found a KEMSA struggling with buying a lot of things, quite a lot of things. Yes, it is good to buy so many things. I can be specific. We were chasing 3,800 SKUs. SKUs are stock keeping units, call them products, including technologies. Now we said, does the country require all this? To us, not. So we don't make decisions for our clients. Let us look at the trends. What have they been ordering over time? Then we realized they were ordering barely 500 items over the last 5 years. Yes, this is information available to us and in our systems. Let us corroborate this information with our clients. So we invited our clients. We had a national dialogue through the county pharmacist. I'm happy the governor has released all of them to come and discuss with us what are their needs. They actually confirmed our fears that KEMSA has been struggling with the limited resources to buy all these molecules, and we settled on those, and we said, let us buy those products. Then there's the traditional policy that a supply chain must hold 6 months of stock in its warehouse. Do we have money to keep 6 months of stock? We said, let us do what we call shrink and grow. Let us be realistic. Let us keep stocks for 3 months and churn around, because those are the small resources we have. So we decided to shrink and said, keep amoxicillin for 3 months, not for 6 months, because 6 months would be too expensive. So by smartly looking at the products and the time we need to keep our stocks, and we went into bulk buying. So, it's different for you to buy things, and it's different for KEMSA to buy things in bulk. We get the economies of scale. We address the affordability issues. Then, because of time, I'll rush through. We looked at framework contracts. We found a KEMSA that was struggling to give contracts every year. So, before you realize, the contract is finished and you have no supplies. So we went into framework contracts, minimum of 2 years, so that a supplier has a predictable deliveries that they make. So, and then digitization, finally. Digitization, very, very key. We have what we call an ILMS, which of course our Excellency, the Deputy President and the President and my Minister have always said we move to DHA, fine. But at the moment, we have the ILMIS, which has, let me just talk about one module called CWAS. CWAS is very good for us. Commodity Early Warning and Alert System. So at all levels, it will tell us where do we have stockouts or overstocks. Is KEMSA overkeeping? Our facilities also overkeeping? What are the optimal? So it gives us alert in terms of colors, to tell us, now there is a lot of stock at KEMSA. Can you offload this before you initiate procurement? I can see I'm being pushed for time. I recognize that, and I thank you very much. I'm ready for any questions.
Thank you. Thank you so much. Round of applause to all the panelists. Please, let's have our seats as we just have Governor Mudomi Njuki wrap up in just 2 minutes, please. And then you call CS Aden Duale to proceed with the program. Rest of panelists, we want to thank you so much. Let's have our seats.
Your Excellency, I just thought will not do justice to one aspect of human resource that we haven't spoken about, and that is coordination between the national government, that is MOH, and the county governments on the issue of human resource. And that coordination is what would really deliver the results that we desire and avoid the industrial arrest that we've had at the moment. Initially, we used to have situations where we had a standoff between the MOH and the counties on the issue of industrial unrest. But nowadays, Your Excellency, we sit and
another session, which will be presided over by His Excellency the President, so that we can have takeaways. But allow me, in terms of delivery of government, both levels of government, to say we have made progress. In 2022, President William Ruto and the team that were campaigning for his election as president promised we will reform the healthcare system, something that we had struggled for many years without success because of the pushback by political interest, business interest, fraud and cartels that were benefiting from the misfortune of the people of Kenya by way of illness, profiteers, and all manner of characters. And the pushback has been there. Those of you conversant with Kenya's political discourse know President Mwai Kibaki, through Minister Charity Ngilu, tried this thing. There was pushback and he gave up. We also know, those of us who have been following Kenyan political issues, President Uhuru Kenyatta, through, I think Kibaki was through Professor Anyang' Nyong'o, Uhuru Kenyatta through Charity Ngilu, or is it Charity Kariuki? So Sisiri Kariuki, I think, tried under the Big Four agenda. UEC was there, pushback, he gave up. So President Ruto said, we will reform this thing. Luckily, he expected the pushback would be there, but he promised the country that he will weather the storm, risk his popularity in the short term until we get this thing right, and his popularity will be back. Imefanyika, haijafanyika. The noises that you used to hear that SHA is not working, whoever is criticizing SHA now is whispering. But when we started, especially the initial months of rollout, it was terrible. You would think that Kenya has come to a standstill. How Kenya is a mess. By that time, we had not even activated some of the funds, like the ECCIF, the Emergency Chronic and Critical Illness Fund, was not operational. So there was chaos all over the place. But today, it is true there are people still who are criticizing, which is also okay because you just make us perfect things. Sometimes the only thing we ask is that you do it, those who are criticizing us should do it factually, not through generalities and through falsehoods. So this has been a heavy lifting of 4 years of hard work by the national government and county governments and the people of Kenya. We've made progress. And what we have said in the last 2 days, and we'll be concluding this afternoon, is there is still work to be done. We need to fine-tune things, but at least now, the framework and the system is in place. The program is now on its track. We just need to fine-tune a few things. What are the 5 things that we must now work on going forward? Number 1, the people. And I'm summarizing what we have said from yesterday morning. The people. The universal health coverage, Taifa Care, is about the health of the people of Kenya. So the bottom line is about the people. Better quality healthcare for the people of Kenya. How far have we come? From 8 million to 32.3 million today. Isn't that a great progress in terms of universality? Because we have had a healthcare program before. NHIF had a public medical insurance cover, but 8 million, 32.3 million, a huge leap, and still counting. I have been advised by those who are better than me in mathematics that we are now around 60% coverage. 32.3 million is about 60% coverage. If you add those Kenyans who are on a private medical insurance, we are approaching 60-something% coverage. That is not a small measure. Compare it with other countries for you to understand. Minister Duale and the team there, President Ruto, and all of us, when we visit other countries or leaders of other countries visit us, they're asking us, how did you get to pull by now 32 million Kenyans on UHC? And counting, because we must up the game. I am advised that 75% plus is what becomes universal health coverage. We are almost there. Some counties have achieved universality. I salute Governor Abdulswamad of Mombasa and 3 other colleagues of his who are now in the 70 plus, with Mombasa leading. It appeared impossible 4 years ago. Today, universality of health care is a reality because of numbers, the number of Kenyans who have some form of medical cover, which may not be perfect, which is being perfected, which is being fine-tuned, but at least when they fall sick, they do not have to rely on quacks, magicians, sorcerers, and manipulative religious leaders, some of whom take advantage of sick people. They have a medical cover. That is what universality looks like. We are smelling it. It's around the corner. Some counties have achieved it, others are on the way. So the target, therefore, we are hoping by the end of this year, we are talking about 40 million. By the time we go to the election, we should be talking about 45, 46. If you add the ones with private medical insurance, almost every person in this country will be having a medical insurance. Tuendelee tusiendelee. It is about the people. We must carry the people along. It was not possible under NHIF for someone without a job, without some ascertainable income source to be covered. Now, everybody, from the indigent to the poorest to whoever does not have anything is eligible. That is transformation. And we applaud all of us for the progress this far. There is still work to be done. We've treated, you've heard the numbers, I think 20 million patients, who have been treated in the primary health facilities. We've heard the money we have used. We've received 27 billion so far under the primary health care. We have disbursed 24 billion, and 67%, almost 70% of that money has gone to county government facilities under the primary health care fund. Today, the sustainability and the financing of private health, of public health facilities is now becoming a reality. We still have work to do to improve on that. The people, the numbers around the people of Kenya who are covered, what they are benefiting from, and the targets for the future is one of the things we must work towards, because these numbers are not just statistics, they are about human beings. And universality is about the numbers. Number two is the health workers. In 2022, we didn't have frontline health workers. Some counties had community health volunteers, others did not have. So President Ruto and the Council of Governors met and agreed to have uniformity. Today, we have an army of 107,000 community health promoters, paid a stipend, half by county governments, half by national governments, leading the war against disease in the villages and the households of Kenya. 107,000. And yesterday, the president launched the next phase of replenishing their kits so that they can have better kits for testing and diagnosis and doing household health advice with better kits. We are also, the president has also talked about the possibility of us reviewing their stipend to make sure that we have a motivated frontline army. But we also have made progress. You saw in the statistics from the president, from myself, from the minister, from the Council of Governors, that we have also, the national government has been able to post or to place 24,000 interns, medical interns, health workers, CHPs, medical interns, 262 registrars who have been facilitated to further their education and to specialize. But there is a commitment now which is being realized at the moment of hiring 5,000 nurses and midwives to protect especially our mothers, to make sure that we achieve that aspect of our health system. So about personnel. But we have also been able now to regularize the employment of 7,800 UHC staff. Again, work in progress. There are small things we need to fine tune. And we've just had a discussion with the chair COG. We have agreed what we need to do on that UHC to make it a seamless part of our healthcare worker system as possible. So the personnel, it's about the people, it's about the health workers. That's what we've been talking about the last 2 days. Number three is about the equipment. If you enroll people and give them a medical cover, and they have a medical health worker either coming at home as a CHP or in the hospital as a nurse or a doctor, that's not enough. And by the way, Governor Abdullahi of Wajir, the chair of the council, was telling me there were 800 doctors. Now we are talking about 5,000 doctors. I didn't know. He was also telling me when he started in Wajir, the first time as governor, he had only one doctor at the main hospital in Wajir. Today, he has 70 doctors in Wajir, including 20 specialists within Wajir County. Is that correct, Mr. Chairman? Yeah. So that is what personnel issues, that is the journey we've covered, and it's still work in progress. But number 3, I said it's about equipment. You have the people, you have the health worker, but they need an interface called equipment. Therefore, through the National Equipment Support Program, we have placed so far equipment worth 9.8 billion shillings in 239 health facilities in 44 counties of the Republic of Kenya. And that work is ongoing. Equipment you will not have imagined. CT scans, the MRIs, the lab equipment, and so forth. There is a lot of equipment placement ongoing through a fee-for-service arrangement, whereby it is up to the person who owns the equipment to place the equipment, take care of the equipment, look for the consumables, make sure the equipment is working, maintain it, and the work of the patient is to come and get diagnosis. And once that diagnosis is done, the bill is sent to SHA, and SHA settles the bill. So it is up to the owners of the equipment to make sure the equipment is working, because if it's not working, they will not be paid. They are paid for every service that they deliver. So again, this equipment thing is work in progress. We have looking forward. We need to work on level 2 and 3 a little more, so because that's where much of the early diagnosis is done. And I think that progress is something we need to be proud of. So you have the people, you have the health workers, you have the equipment. Number 4 is, and maybe this should have come earlier, the legal and institutional framework to deliver. Maybe it should have come earlier, after the people. The legal and institutional framework. That is why, and here we salute our houses of parliament, and we salute all of us for our various roles that we played to make sure that we have anchored this program under sound legal and institutional framework. Today, the laws are in place. The Primary Health Care Act, the Social Health Insurance Act, the Digital Health Act, and the FIFA, which is Facility Improvement Financing Act. You have the 4 laws. But we also have the funds, the 4 funds. Under the Facility Improvement Finance Act, you have the Facility Improvement Finance, which is retained at the facility to improve the quality, the service, the level of service. But we have the other 3 funds: the Primary Health Care Fund, the Social Health Insurance Fund, and the Emergency Chronic and Critical Illness Fund. Work in progress. But we also have the institutions. We have SHA, and we have the Digital Health Agency. That is the framework. And we are being told now, in terms of the future, of 2 legislations that are work in progress. One, and it was raised by the panelists, the high-level panelists who are here just now. One is the Quality of Care and Patient Safety Act, to make sure that this level of service delivery is standardized and of the highest quality. And then there's one which was mentioned by my senior here, Dr. Nyikal, the one on drug something, Kenya Drugs Authority Bill, those two, so that if we go into manufacturing, as we should, as we have said we should, then that is the law that will help us fine-tune that area. That is the work around legal and institutional framework. 90% done, a little bit remaining to perfect it. Then finally, number 5, it is the commodity logistics. We've heard what KEMSA is doing to improve drug supply. We've heard how we've moved from 40% to 90% in terms of availability of the drugs which have been requisitioned. But there is need for more work around KEMSA. And one of the suggestions that came from His Excellency the President, and I have repeated it here, is that the system which KEMSA is calling integrated something, medical, what is that MLIS something? Integrated, give him the mic. Integrated logistics.
Integrated Logistics Management Information System.
That system is good, but it must be interoperable with the data, the medical data under DHA. Because it's about supplying commodities for this system. So you cannot have all the other data separately in this data. The two systems must speak to each other. And that should happen sooner than later. And in the next IBEC, which is on Monday, or maybe the next one, some of the things we agree here, we should pick them up so that we start running with them. So about commodity supply, commodity logistics, we've made some progress. KEMSA was in disarray in 2022. We gave them 1.5 billion. We got them a line of credit of 10 billion, and we are happy with the good work that is ongoing there. But there is more work to be done around health commodities availability. But we have also 922, the National Ambulance Dispatch Center, an emergency number to provide ambulance services to patients who have emergencies, who have medical emergencies. You get the ambulance. First of all, the number is toll-free. That 922 is toll-free. Secondly, it should link you to the nearest available ambulance. And we must make sure the ambulance is available in good time to save lives. But also it is attached, that package is attached to emergency treatment. The first 24 hours of emergency treatment should not be pegged on anything. Whether someone has a cover and a SHA or not, they must be stabilized as now they get registered into SHA and other things follow. So again, around commodity and medical logistics, the ambulances, the commodity availability of drugs and so forth is work in progress. Those are the 5 things: the people, the legal and institutional framework, the workers, the personnel, the equipment, medical equipment, and then the health commodities and logistics. With one enabler, those 5 things, we are fine-tuning them as we fine-tune the main enabler of those 5 pillars of our UHC is going to be digitization. The work that DHA is doing, technology, digitization of how we manage all these pillars is key and is work in progress. And this digitization will help us resolve the biggest threat, the biggest single threat to this program and to all medical insurance programs around the world. Fraud. It is digitization. And what DHA is doing, that will help us fight fraud, because fraud interferes with the medical actuarials. Because the insurance is around actuarial estimates. How many people are paying how much? How many people get sick? What are the benefits like? What is being paid out? Fraud interferes with the health of the actuaries. So DHA has the solution. The sustainability factor is going to be around digitization, technology, and making sure that we fight fraud. Thank you very much. God bless you for your time. And I think we are in a good place. But there is a session coming at 2:30. Around there, the minister will announce what time, where His Excellency the President want to come and listen to what all the participants consider to be the takeaway. What is the take home? What is the experience? What is the agenda around the issues we are raising? Then he will give now the final strategic address, which will now send us back to our workstations. Ifaya. Minister Duale.
Thank you so much. Let's appreciate Prof. I'll request Your Excellency kindly to remain on stage.
Can be difficult and time-consuming, from overdue vendor invoices to employees waiting for payments.
Health promoter before a manager
being impoverished.
That man who's seeing us and that woman who's seeing this town hall, and they have very many questions that they've been wanting to ask or they've been seeking answers. So the people who are here in make it to this town hall, you will have an opportunity to ask any questions on their behalf. You'll be able to get clarity on some of the issues that we think need to be addressed in the healthcare in Kenya. So, ladies and gentlemen, President of the Republic of Kenya, let's be upstanding and we welcome the President. Let's appreciate the President as he walks in. Let's give him a warm, hearty round of applause as he comes into the room for this inaugural presidential town hall on health. Let's be upstanding as we welcome His Excellency President William Ruto, who will be able to take us through this town hall. Karibu sana, Your Excellency. Karibu sana, Your Excellency. Ladies and gentlemen, you can take your seats. Your Excellency, as we plan to start this discussion, I'm a media practitioner as much as I'm a medical doctor. I want us to see and address a certain elephant in the room.
Millions of Kenyans. How
And
much
these are
you pay
some
for
of the
healthcare,
headlines
and whether
that
you even receive healthcare has been decided by an opaque artificial intelligence system. You don't get to see it you don't get to question it. You just get a number. But for many on the ground, an entirely different reality is unfolding.
In the community, perspective and expectations. Walidhani ni kitu itawasaidia kulingana na venye ilitangazwa na serikali. It is so tricky. Unapata mtu aweza afford a meal a day. Unapata anaambiwa he or she is supposed to pay 650 and above. Pesa hata yeye aweza afford. Kwa hivyo, tangu SHA ikuje, kumekuwa na crisis.
Our audit found that it overcharges the poorest Kenyans while undercharging the wealthiest. We also obtained a document showing that the government knew of these risks but launched the system regardless. Knew of these risks but launched the system regardless.
Mr. President, those are some of the things the media has covered. But I want to take you back to 2022, where you made certain promises. One of them was that any mother that delivers will get free diapers. I thought in 2023 I'll be one of the first beneficiaries. I didn't get diapers. What happened?
Thank you very much, Mercy. And good evening, everybody. Welcome. This is a very good event, and thank you very much, Mercy, for asking me that very important and pointed question. But let me put this in context. There are many people who say I was elected in 2022 merely because I said hustler and bottom up. Today, I think you have seen that I made commitments. I had a plan. And I made commitments to the people of Kenya. And it is on that basis that the people of Kenya gave me a mandate. And it is what is expected of every leader, that if you want the mandate to lead a country, you must give the people your plan, your vision, your commitment on what you're going to do. And this evening, I am going to answer, and I'm very happy I saw the commitments I made before the election in 2022. Number one, I think I made like 7 or 8 commitments on matters health alone. 7 or 8 commitments. Commitment number 1, I said that we are going to have a health system that is going to make sure that every citizen can have access to healthcare. I called it that time hustler. But we came and said it should be called Social Health Authority. Today, my commitment on making sure that we have a system that works, a system where Kenyans can access health in a predictable manner, today is a reality, and 32.3 million Kenyans are registered on that platform. Number 1. Number 2, I made a commitment that we are going to have community health promoters. I said then, in good numbers, I can now stand here before you and the people of Kenya that we have 107,800 community health promoters. Trained, properly, deployed, and their stipends paid. I committed then that I was going to work with counties to make sure that their stipend becomes a shared responsibility between the national government and the county governments. Today, half the stipend of community health promoters is paid for by the national government, half the stipend is paid for by county governments, and I want to thank the county governments for working with me on that platform. I did make a commitment that we are also going to make sure that those people who cannot afford to pay, you remember the commitment I said is that everybody is going to pay as per their ability. And those who cannot pay will be paid for by government of Kenya. Today, each and every one of us is paying in accordance with their ability, a percentage of their income. And those who cannot afford to pay, the indigents, we are paying for 560,000 households, representing 2.2 million citizens who the government of Kenya is paying for. That goes to the bottom of what commitment I made, that those who cannot afford will be paid for by the government of Kenya. And secondly, we are also paying for all teenage mothers, because we understand that every teenage mother doesn't have the money. And there we have provided resources for the government of Kenya to pay. Number 4, in that clip, I made the commitment that we are going to work on this from the bottom. I said every health center, every dispensary, every level 4 hospital must work for level 5 and level 6 to work. What have we done? Today, every health center, every dispensary, and I am sure there are people in our midst here today who are managers of health centers, managers or heads of dispensaries, who are going to tell us the difference that has been made by the reforms that we have carried out to every facility at that level. Today, every health facility, every dispensary, number 1, has a management board. Number 2, every facility today, for every patient they see, at the end of the month, they are paid by SHA. Every facility, every dispensary. Because I made a commitment that we must make the dispensary work, we must make the health center work for facilities on the higher level, level 4, level 5, level 6 to work. Today, with confidence, the governors are here, the managers of those facilities, I'm sure they are represented here, they will tell us the difference we have made. Number 4, I made a commitment that we are going to make sure that every mother, the question Mercy has asked me, every mother who gives birth, when they leave hospital, we are going to make sure that they have diapers. Right? That is a commitment that I must fulfill. Because we have already set the mechanism in place. We have already changed the way our Linda Jamii program operates. You remember, the Linda Mama program operated differently from the Linda Jamii. The Linda Mama focused on the mother and on delivery. Today, the Linda Jamii program focuses on the mother, focuses on the child, and focuses on the household. The numbers have changed. Linda Mama was 2,500 paid or refunded for public facilities, 3,500 for private facilities, 6,500 for cesarean section, 10,000 for private hospitals. We have changed that metrics. Today, from 2,500, we now pay 10,000 for all facilities, irrespective of whether they are private, public, or faith-based, for normal delivery. We have increased 4 times what was being paid. Number 2, for cesarean section, which was 5,500 in public facilities, 10,000 in private facilities, we have raised that up to 30,000 for all facilities. So we have equalized all the facilities, because a mother giving birth in a private facility is as good as a mother giving birth in a public facility or a faith-based facility. We have equalized that whole space. And because we have built now the ecosystem, just 2 weeks ago, you remember the gentleman who asked there and said about emergency, and that he told me that time in 2022, I think it was June, he told me government must operationalize the emergency facility because too many people will lose their lives, because in an emergency, if you go to a hospital, the first thing a hospital will ask you, who is going to pay the bill? And in the process of asking all those questions and finding out who will pay the bill, we lose lives, we lose people. That is why we went to Parliament, we passed the law, we now have an emergency, chronic, and critical illness fund that now funds emergencies. And 2-3 weeks ago, we launched that facility, which comes complete with an ambulance facility paid for, emergency service for the first 24 hours paid for, and beneficiaries don't have to be members of any insurance facility, including SHA. You don't have to be a member of SHA. So long as you are in an emergency, the government of Kenya, as was requested, as I was told in 2022, and I committed to do it, today I have discharged that responsibility. 2 weeks ago, we launched the facility and we are moving. You remember, in that clip, I promised that we were going to have the health insurance by 2022 end. It wasn't possible until 2023 end. Why? Because of the process. We were taken to court, we were stopped here, we had to go back, we had to do this, but ultimately, we've kept that promise. We have now finished with the emergency. I can tell this auditorium that by the time I complete my term, my first term, I can tell you I will have discharged all the commitments I had made and made sure that every mother who walks out of hospital will walk out with the diapers once they give birth. Let me also say, another gentleman, and I wish he was in this room today, who told me that time that I was a candidate then, Mr. Deputy President, please find a mechanism where citizens can contribute, not a fixed number as we were doing, but a percentage of their income, a percentage of their salary. Today, in this auditorium, all of us know here that each one of us contributes 2.75% of their salary or income. The people who are paying the most at 5% have come down to 2.75%. Those of us, like me, who was paying 0.01% of my salary, today I pay 2.75%. We have made contributions equal as a function of your income. That was what I was asked by that gentleman. That is what we have done. So, in short, on that list of the commitments that I made to the people of Kenya, I will be ready for the exam next year. I will be ready for the exam next year. And my target is to get 100%.
Okay, all right. Sorry for that. Thank you. Those are very good. But I want to take you to the headlines. One of the headlines was SHA ni Chief Nivilio na Mateso. And the other one, and I'm glad that some of the members of parliament are here, the MPs actually are saying SHA isn't working. But here you're telling us SHA is working. We have X number of Kenyans who have been registered. What do you have to say? And it's been
Thank you very much,
there.
Mercy. That is great. That's another beautiful question. Because facts are very stubborn, you know, and reality is different from what gets said. One of the headlines tells us, for example, that there is a 104 billion shilling skunk on our digital health program. That we had signed a contract of 104 billion. I think this one here, the skunk, you know, of 104 UHC take upgrade. First, let me tell you that there is no 104 billion contract. First, what we have done is we have designed a digital system, and I want to say this with clarity. This whole ecosystem would not have been possible if we didn't have a digital system to make sure that everything, as I said earlier in the day, that every patient must be visible. Every treatment must be traceable. And every payment must be accountable. That is what the digital system enables us to do. And Akili, what did we do? We did not buy the system. Just the same way, today we have MRI machines, we have CT scan machines, we have theater machines worth billions of shillings, but we haven't paid a single one of them. What we have done, what we have told manufacturers is they invest in the machines. They bring the machines, we pay for service. For every one service, we pay. It is their business to maintain, to make sure the machines are working. It is their business to make sure that the machines are operational. They service the machines, they provide the consumables. Ours is not to buy machines. Ours is to provide service for citizens who want treatment. It is the same thing we did. We asked companies to invest their money in a digital platform, a health digital platform. They invest the money, we pay for the service. And we went to Parliament. And we went to the Kenyan public. And we agreed on the rates. We said that for SHA and all the other facilities, we are not going to spend more than 5% of the resources we collect from the people of Kenya for management. And for your information, the management cost of 5% includes the payment for the digital platform that we are using. Do you understand what I'm saying? Let me repeat. Let me go back. The management cost under NHIF was 40% of the collections at one point. In 2022, it was 17% of collections went to management. Under SHA, we have brought down management cost from 17% in NHIF to 5% in SHA, number one. And the cost of technology that we are using is included inside the 5%. That is where we begin. And we have said, for facilities, and I saw one of the headlines there saying that there is a ghost company being paid 1.2 billion by hospitals. You know, for your information, hospitals do not pay any private entity. Hospitals pay DHA. And the cost is this, so this skunk thing is a fallacy. You know, ile mimi naita saa zingine ufala, ndio hiyo. Na hiyo 1.2, mnaona pale, there is a 1.2 billion, sijui some farm. I can confirm to you that that is money paid to DHA. And the money paid to DHA is in law. Facilities pay 2%, but with a maximum of 5,000 shillings per claim. And it is in law. It is not something you go and negotiate in the bush. It is in law. And we have made sure, and I can answer any question from anybody on the amounts of money we are paying for technology. And every payment is underwritten by law in regulations to make sure that we protect public assets. Let me ask the good gentleman from DHA, Anthony, is right there. Anthony there is a professional. He's not a politician. And he is the CEO of DHA. Anthony, can you speak to this 100 and something billion contract?
Thank you, Your Excellency. It is not correct and not true that the Social Health Authority has done any upgrade on any government has invested in 104 billion technology upgrade. Your Excellency, what we did is build a digital superhighway, consumed of 43 systems, Your Excellency, to support universal health coverage. What are these systems, Your Excellency? The first is we realize our public hospitals, where many Kenyans go, do not have digital infrastructure to provide services online. Your Excellency, we brought to them 4 key things. Number 1, Your Excellency, we gave them gadgets, which are tablets or computers, that the private sector has invested for a period of 10 years with all upgrade, all maintenance, and all support. What has that done to us? Today, Your Excellency, the public hospitals, where many Kenyans used to go and get services, Your Excellency, used to receive only 35% of PHC under NHIF. As we speak today, 62% of that money is going where services are being provided. This is because we enhanced the digital infrastructure at the hospital level. We gave them, Your Excellency, software. This software has helped them with efficiency. This software, Your Excellency, helped them to track and be accountable for every patient, for every claim. During the days of NHIF, hospitals used to have files. They used to be approved in batches. They used to be transported, taken to county NHIF offices. They will still be transported, taken to the regional offices for approval. They will still be transported, taken to headquarters for approval. They used to be approved in batches. They used not to be checked. There was no accountability. As we see today, Your Excellency, every claim is tracked because we have enhanced that public sector, Your Excellency. The second area that we looked at the superhighway, Your Excellency, is many Kenyans used to go to hospitals. When they're in the hospitals, they will receive a service. But that service, how they have been written, how they have been identified, is different in the second hospital. That is why you couldn't work with your data. That is why you couldn't have data portability. We looked at 6 key systems in that area. 1 is a client registry. Every Kenyan today is identified uniquely using your ID and your fingers. It eliminated all the cards that we used to print. And that is the role of technology, is to bring efficiency, Your Excellency. The second part was on the facilities, Your Excellency. You remember there were facilities that were doing more surgeries than Kenyatta, Your Excellency. And they will use that because there was no digital system. They will use that to do claims. They will use that to frown public funds, Your Excellency. Today, we have a single point of truth for every facility to safeguard the safety of Kenyans. No facility can provide services in this ecosystem if you have not been licensed in that, to provide those services. No facility can provide services that has not been licensed, Your Excellency. That is what has eliminated what we used to have, like the hospital that is in Kino, Your Excellency. We looked at the health workers, Your Excellency. There used to be fake doctors that want to use the doctor's professional, Your Excellency, and cheat Kenyans. You will walk to hospital. You don't know, Your Excellency, whether this is a doctor in front of you, Your Excellency. We created a single point of truth where only licensed doctors, the specialties they have, Your Excellency, the systems only allow them to provide that service, Your Excellency. We look at other areas, Your Excellency. Many Kenyans used to walk. They carry books, Your Excellency. Those books used to get lost, Your Excellency. We provided what is called a shared health record, Your Excellency, where today, if you download the Afya Yangu app, you will see all your claims, you will see all your prescriptions, you will see all your doctors, and you are able to see all your information within your phone. That eliminates all the paperwork that, Your Excellency, we used to have. That area, Your Excellency, is called Health Information Exchange. We are the second country in Africa to be and the 10th in the world, Your Excellency, to do that, Your Excellency. We look at the whole area of, Your Excellency, logistics. KEMSA digitization, Your Excellency. How do we ensure that the drugs that are provided are correct? How do we ensure the safety of the drugs of Kenyans? We track these drugs from the manufacturers to the time it is dispensed in the patient, Your Excellency. For the safety of the Kenyan people, and as well as to ensure that the drugs that are dispensed are only the authorized drugs. That system has three key ecosystems: a national logistic management system, a track and trace management system, as well as, Your Excellency, what is called order management. You saw today, Your Excellency, in some of our counties, the counties do not have to wait to see where are the trucks that are bringing our drugs. They don't have to wait, Your Excellency, to see which drugs I need to order. Before they will order a lot of drugs, Your Excellency, they will put them in store, but maybe their demand does not need them to do that, Your Excellency. Today with this ecosystem, we are not, the public hospitals as well as our ecosystem is not to provide that, Your Excellency. We looked at the areas of telemedicine. We don't have enough expertise. How do our doctors consult? How do they talk to one another? How do they support the patient to provide them the best services? And we brought in the telemedicine platform that are running in our ecosystem, Your Excellency, today. Your Excellency, we looked at the analytics. You saw today, Your Excellency, we are reading patterns. We are able to see patterns of hospitals that want to defraud our ecosystem, Your Excellency. And we are able to analyze them. Systems are for efficiency, Your Excellency. And that is what we have built. 43 systems, Your Excellency, that does not only support SHA, but more protect the Kenyan people from fake drugs, from fraud, and give them efficiencies, Your Excellency.
Can you tell us, Anthony, how much money have you paid to the service providers in the last 2 years under this program? Especially for SHA, for example. How much money have you paid?
Your Excellency, for the providers of technology, SHA has only paid around 500 million. How does SHA calculate this, Your Excellency? It is in our regulation. We went to the Kenyan people, and the Kenyan people told us for the Social Health Authority, within their 5%, they only pay 25 shillings for every active member of the Social Health Authority. So anytime the Social Health Authority has an active member, you pay 25 shillings, not per month, Your Excellency, but per year, Your Excellency. For the last 2 years, around 500 million, Your Excellency.
So 500 million paid for this technology that we were told that we were going to pay 100 billion.
Correct, Your Excellency.
Okay, so the writers of the headlines have answers. Let me also ask you, maybe Mercy this time round. So, because of the efficiency we are building, first, how many gadgets have we supplied, and how much did the hospitals pay?
Your Excellency, as of today, we have supplied 42,327 gadgets. If you walk to any of your dispensary today, in the lowest village you can be, you will find a gadget there, Your Excellency. The hospital has not paid for a cent.
They have not paid for it. We have provided those facilities.
Yes, Your Excellency.
And it is part of the digital health system.
Yes, Your Excellency.
Mercy, you inherited an organization called NHIF.
Yes, Your Excellency.
With 1,000, how many workers, and how many workers do you have today?
Your Excellency, we inherited an organization that had close to 1,737 workers. Today, our establishment has 815 health workers who work at SHA. And Your Excellency, just because of that technology, we've been able to halve our workforce, but also additionally, Your Excellency, increase our claims processing. I think it is important for Kenyans to understand in any one single day, 24 hours, SHA receives about 26,000 claims. These are 26,000 Kenyans who've walked in and walked out of a health facility and a claim has been lodged at SHA. And because of the system and the digital components that have just been described, the SHA Claims Management Office that has 35 people They're able to go through 26,000 claims in a day and close to 1 million claims in a month. That's the efficiency we've gained.
We inherited an organization of 1,700 plus. We have taken close to 1,000 Kenyans back to public service to go and do something else. We have remained with 800 in SHA. So we have reduced by half the staff because of technology. And we are processing more claims than were being processed by 1,800 staff. That is how efficiency looks like. And that is how transformation is framed. And that is what we have achieved. I don't know whether, Mercy, I have answered your question.
Almost slightly. The one that is still top of my head is the reforms that we are talking about were passed through Parliament. And I'll narrow down to SHA. One of the headlines is the members of Parliament saying that SHA is not working, but they passed this law. I don't know, I cannot reconcile those two things because our laws pass through these members of Parliament. It may not be your question, but the buck stops with you.
Okay, Mercy. You know, there are many facets of this. Maybe I remember that at some point, you know, because of the challenges that were there in SHA, some people were almost giving up. Because what we have done in transforming SHA or NHIF to SHA is something phenomenal. You know, we replaced one piece of legislation with 5 pieces of legislation. We transformed a whole ecosystem. You have heard what Antonia said. We had all manner of, you know, challenges from that fellow called Mugo, who was not a doctor of any shade, but he was busy treating people in some clinic. Because of technology today, Mr. Mugo has no job. He cannot fake anything. From that all the way to the hospital we had in Kino that was doing surgeries, more surgeries than Kenyatta Hospital. Today, the gentleman in Kino has no business because the fake things he used to do is not possible anymore. Same thing to the fake claims we used to have. I said earlier, we used to have claims of people, somebody who has been amputated 7 times. And then you ask yourself, how many legs did this person have? That is no longer possible today. And we had some hospitals that had more accountants than health workers. You ask yourselves, what are accountants doing, more accountants doing in a hospital? Because it was a fraudulent claim making enterprise more than they were hospitals. We've stopped all that. And that is the reason why this exercise has been a big battle. Those people who lost their schemes and enterprises, sponsored headlines, sponsored cases, because we were interfering with their business. But I can proudly stand here today and say the people of Kenya finally have a system that they can audit, that they can see, and that is functional. And today there are witnesses across the nation. Go to any village, go to any part of Kenya. Even when you go to a fundraising event, And let us call a spade a spade. The WhatsApp groups that we all used to have in our phones have gone down. True or not true? Yes, the WhatsApp groups have stopped. Even when you go to a fundraising today, they will tell you, SHA has paid 300,000, we are looking for 100 or 200,000. It used never to happen before. So, statistics, numbers, have a way of saying things better than any statement. So, Mercy, we have members of this parliament here. I don't know whether we have a member of parliament there. Do we have any other member of parliament? Please, who want to, it is said that you as members of parliament said SHA does not work. Mutueleze, come from your point of view.
Your Excellency, my name is Senator Jackson Mandoga. I'm the chair of the Senate Health Committee, and I want to stand here to confirm, Your Excellency, that SHA is working. The period members, a few members of parliament were saying it was not working, was actually during the first phase of implementation. With DAJ, Your Excellency, when they supplied the gadgets to all health facilities, all Kenyans were now able to access SHA. In fact, I've just received a message from one of the members of County Assembly who said he was admitted in June 14. He's a former nominated MCA, Duncan, and SHA paid all his bills. SHA is working, and there is evidence that it is working.
Esther, do you want to contradict what Mandago said? Or?
No, Your Excellency. SHA is working, but I think the biggest failure that we're having, that the Ministry of Health has to undertake, which we try to do as in terms of civic, is to educate the people on how to onboard, how to review their funding model if they're having a problem with the premium that they've been given. Because every single day, and then to have an effective customer service line, an effective one where any citizen can call English, Swahili, and get information. Because yesterday I got a phone call from a lady who was admitted in Nazarene. Immediately I called somebody and I said, this is the SHA number, this is the ID number. They are being detained because what happened is, and this is something we need to educate Kenyans, as soon as she was admitted, she signed up. But she had already been in hospital like for a week. So the bill came to about 100,000. Now, such cases, I think the hospitals need to be educated. When you're admitting somebody, you need to make sure that they are registered. And then also the effective advertising. Social media is so cheap. Ministry of Health has to continuously educate Kenyans on how to onboard, how to have your premium reviewed if it's too high. How, before we used to say there's a waiting period of 3 months. Now we don't have a waiting period. But this lady in Nazarene Hospital is being detained because of 100,000. And the reason is because she joined 1 or 2 weeks after admission. So that waiting period, how do we deal with it? So I think it's important that the Ministry of Health really does a lot. They're letting you down.
Is there anything members of parliament can do?
I mean, we do civic.
Apart from asking the ministry, which you are right?
Yeah, we do civic. Every time we have an event, like if I have an event for GAF, I will call SHA to come in and talk and educate to on board. But now, because of the biometrics, it normally has to be done in the hospitals. But I've seen that they come in as well and they're doing it in most of my events, but it's not enough. We're not netting everyone. I mean, Nairobi has about 5-6 million people.
So information.
Information, online, information, with the CHPs.
Do you have a working line, Mercy? And she said you need a working line, helpline.
Yes, Your Excellency, and we do take the comment seriously. We are doing more to talk to Kenyans. We have the line 147, and it's accessible 24 hours. But we also have a county infrastructure. Each of the 47 counties has a SHA office, and additionally, we have SHA officers too, per Huduma Center across the country. But that being said, Your Excellency, we do take...
what did you say the number was again?
147. 147.
So a citizen can dial...
147.
147.
And it goes to our call center that has callers waiting there to attend to the citizen.
Do we have people who speak Swahili there?
Ndio, tukana Wakenya ambao wanaongea Kiswahili
That is what
hapo.
Esther was asking.
Kuna Wakenya ambao wanaongea Kiswahili kwa call center.
Kwa hiyo call center.
Ndio.
So to everybody listening to us in every part of Kenya, it is good for you to get information. And the information you can get, if you don't get from your CHP, if you cannot get from anybody, dial 147 and you can ask any question and your questions will be answered. And for people like what Esther has said, that there is a citizen who was admitted without registering for SHA, and then she registered halfway through her treatment or his treatment. That needs to be looked into. How do we manage that? Do you want to say something, Mercy?
Thank you. Thank you for that observation, Mheshimiwa. One, Your Excellency, we must remember and remind Kenyans that for them to be able to access the SHIF benefits, they must register and they must contribute before they go to hospital. When you go to hospital for a week or even 5 days, 3 days, SHA needs that visit to be notified in the system. So it means for those 3 days, 7 days, there's been no notification at SHA. It means SHA cannot verify that that is an actual visit. It means any pre-authorization was not done, and SHA basically is blind that you're in the hospital. So Kenyans need to be reminded that if you need to be able to be admitted and you need the SHIF benefit, register, pay for it before you go to hospital. Once you're in hospital, the hospital should provide us a notification of your visit and we start tracking your care and treatment. So it is important in controlling fraud and ensuring that we're able to actually be accountable for that money that we shall pay the provider.
For example, I think I talked about Lydia. I don't know whether Lydia is in the audience. Do we have Lydia in the audience? I talked about Lydia. Is she there? Ako hapa Lydia huyo? She's not here?
She's right
Ako wapi?
at the top there.
Lydia traveled from Matu today, Your Excellency, so she's right here with her mother. Yes.
With the mother?
Yes.
Mama ako hapa?
Yes, guardian ako hapo.
Wapi mam? Oh, yuko pale. So, like the case of Lydia here, who developed a complication. Her mother had paid 7,000 shillings as her contribution to Social Health Insurance Fund. Mama, hebu tueleze, mama yuko pale. Mama, habari? Habari yako mam?
Salama.
Very good. Unaitwa nani?
Mimi naitwa Naomi Mutendwa.
Naomi, wewe ndio mama wa Lydia? Very good. So, uliregister kwa SHA? Ukalipa pesa ngapi?
10,200.
10,200. Alafu mtoto ulimpeleka hospitali?
Nilimpeleka hospitali.
Akatibiwa?
Hapa Kenyatta akatibiwa, lakini nilipeleka Garissa nikaambiwa nimlete Kenyatta na akatibiwa na katoka vizuri.
Okay. Bili ya hospitali ilikuja pesa ngapi?
Ilitoka na 1,168.
1,168. Ulilipa shilingi ngapi kwa hiyo 1,168?
Hakuna kitu nililipa.
Na nimeambiwa ya kwamba anafanya form 4.
Anafanya form 4 sasa.
Mwaka huu. Lydia, my very best wishes on your exams. Ukienda. Na asante sana mama kwa kuja. Kwa sababu niliongea mambo yako, nilielezwa na watu wa SHA mapema leo. Asante sana kwa kuja. Now, unaweza keti mama. One of my staff, Dr. Mwai, who worked with me on this program, and I remember sitting down with Dr. Mwai in 2021 2021. I don't know whether Dr. Mwai is in the audience. Okay. You know, Dr. Mwai was telling me about an experience he had, I think, in the last 2 weeks, about somebody who called him and asked him, why are you people asking me to pay 8,000 shillings? Can you tell me? I remember you mentioned to me, Daktari.
Yes, thank you very much, Your Excellency. The issue was when you are dealing with the issue of, are we charging people more? So the first thing that people have argued is that we should have introduced waiting time. I hear a lot of that. But you said that when somebody is in problems, you don't tell them to first wait. So when they come in, they pay, and then you cover them. So a friend of mine who I consider reasonably learned, in my own opinion, called me and asked me that they are trying to revise their premium because their premium is around 8,000. And I asked her, you want to revise the premium, why? You have a patient? Is it a new person? Are you preparing for any eventuality you get sick? So he told me that the patient is actually receiving dialysis or want to start the dialysis. So I asked, the dialysis, SHA is paying 10,650 per session. Majority of them take 2 sessions. So roughly 21,300 there. All right? Now, they pay that for 52 weeks in a year, which is 1.1 million plus. Now, I asked my friend, where were you come to a little bit to me, SHA is, you are saying your patient is in hospital, you want to pay 8,000, you get 1.1 million. Now, you are my sabus in rice. What is a no-brainer? You are complaining, yet you can already see the benefit SHA is giving you far outweighs the cost, actually, what you are doing. Akanyamaza na akalipa. So why I'm saying this is because there is also a move for people to not want to understand the money we are paying with, where is it coming from? It's coming from each and every person, contributions based on ability to pay, and that is what you correct, so that somebody who paid 8,000 receives a benefit of a dialysis at 1.1 million. Thank you, Excellency.
The point I'm trying to make here is we have said the following. We have said for outpatient, every citizen of Kenya, so long as you are registered in SHA, you will walk into any facility, public, private, faith-based facility, anywhere in Kenya. So long as you're registered in SHA, you will walk in and walk out without paying a single cent for outpatient facility. If you have to be admitted for surgery or for other facilities, that is when you have to make a contribution. Or the government of Kenya, if you are not able, the government of Kenya will pay for you. But you will be assessed, and everybody will be assessed for what they can pay. For the case of Mama Lydia, she was assessed for her and her family. She was assessed for 10,200, as she said, for a whole year, for herself and her family. Lydia alone, SHA has paid 168,000. If her next child became sick, they will be paid for. If she became sick, she will be paid for the next 1 year, for paying 10,200. Right? Simple mathematics. That is what that gentleman in the clip was saying. It must be contributory on ability. That's the point I'm trying to make. So we must all understand that for this to work, we have first removed In NHIF, you paid and waited for 3 months for the cover to be active. In fact, many people are pushing me to say, why don't you go back to that? No. You cannot tell a sick person, pay, wait for 3 months so that you can come for treatment. What about if they die? Or if something happens to them? So the moment they come to hospital, if they are not registered, we register them, they pay immediately, and they access service at that point in time. That is how we have changed the metrics. And that is how we are going to do it going into the future. I remember saying also earlier about cancer. You know, we had a big problem with cancer, as we all know, and treatment. We have again upped resources for cancer from 500,000 to now 800,000 cover for all citizens registered under SHA. So that is the trajectory. I don't know, Mercy, whether, again, I have answered your question.
Yes, Mr. President, but I don't want to be accused of inviting you to a town hall of this magnitude and asking all the questions. I think we should let the Kenyans here also ask some questions, and I'll hold mine for later so that we can field questions from the room, if you allow that. So you can pick.
So I'm the one to pick the, I thought you were going to do that for me. Okay, I see some beautiful lady there. Madam, you have the floor.
So, good evening, Mr. President. My name is Lois. I'm a person with albinism, and I stand here to speak for persons with albinism and persons with vitiligo. For us, sunscreen lotion is an essential. It's not for cosmetic purposes, and mostly it's not covered using the social insurance cover. So, whom do we go to, or what approach do we take for us to make sure that we have it, since most of the times the government provides it, but it is not enough, and at times it's not there at the hospitals. So how do we go to, where do we go to, or how can we go about it?
Very good, thank you very much. Did you say, what's your name?
My name is Lois.
Lois.
Yes.
Lois needs an answer. Yeah? Lois needs an answer.
Thank you. Thank you, Lois, for that question. Your Excellency, vitiligo, I'm not a dermatologist, but I'm a doctor. And vitiligo is a condition where the cells that are called melanocytes in your body are not able to produce the needed melanin. Now, the problem with patients who suffer from vitiligo is that they're exposed to the sun, and because of that exposure to the sun, they're at risk of getting cancer. And so actually we need to protect patients who have vitiligo by ensuring that they have sunscreen, they have the necessary steroids, and they also have UV light therapies. The madam is correct. In terms of our current benefit package, what we have in offer as government is that KEMSA, and I hope Dr. Wako is in the room, do procure sunscreen at subsidized rates to be able to ensure that those who have vitiligo can access that sunscreen. However, at SHA, we have not yet started reimbursing for sunscreen, so you won't be able to get it from SHA reimbursements. Your Excellency, the case of vitiligo accompanies many other cases when it comes to healthcare. And what is important for our country is to start on a journey of progression. As we start here today, we are covering a large burden of disease, the things that cause the most harm. We are by no means saying we cover everything, but there is a scientific process of being able to determine how we add more benefits into our package to be able to cover everyone. And that's the journey of UHC that all countries must go through. So the short answer right now, Your Excellency, is that when Madame needs care, she'll be able to go to a PHC center. But unfortunately, what she needs in terms of sunscreen and some antisteroids are not yet available in the package, but will be available as we continue mobilizing more resources.
So what do we tell Lois? Do we tell Lois
coming soon?
How much time do we need? And Lois, I agree with you. We have a huge benefit package. And I remember I sat down with my team and we said, we need to look at a benefit package that we can afford. Let me tell you, Lois, today we are paying 2.75% of our income. We should know that countries that provide universal health coverage pay up to 15%. Go to any country. It is not 2.75%. It is 15% for them to provide the full package. We have started with the package that we have. But I think who have conditions like the one Lois has said, including vitiligo and all the others, I think it is time that we come back to Lois and tell her at what point will we include the sunscreen she is looking for. And I want to tell you this, Lois. It is homework you have given to me. Let me take it home.
And Your Excellency,
I will have an answer for you and for all the others who are like yourself.
And Your Excellency, just to add, you've actually commissioned the Ministry of Health to review the benefit package, and you've given us a deadline of ending October. So all Kenyans are invited. We'll be having public participation on the new benefit package for SHA, and we'll be looking for Lois and all other members who want more benefits to be included. And we'll give the reports on the new benefit package at the end of October.
Thank you very much. In our midst, I want to listen to a manager of a facility. I have said here that facilities, I want somebody who runs a health center or a dispensary.
Mr. President, we have one on standby at Ruto. If we have that link ready, yeah, we have Alice Ndwiga at Ruto Health Center. But as we get her ready, maybe we can pick one from the room.
Do we have a manager?
Here she goes. This is Alice Ndwiga.
Okay.
County.
Alice Sabari.
Good evening.
Good evening, Alice. How are you?
I'm very well.
Habari ya Ruto?
Ruto iko baridi mingi, but tuko salama.
Very good. Tell me, Alice.
Yes, please.
Before UHC, is there a difference between are you a manager of that facility? Or
yes, I am. Maybe I can introduce myself, His Excellency. My name is Alice Ndwiga, Facility Manager at Ruto Hospital, Level 4.
Yes.
We are here at Dagoretti Sub-County.
Okay.
The North.
Okay.
Kangwari Ward.
Let me ask you, Alice. What is your experience as a manager? The journey over the last 3 years. What is your experience? How has your facility improved? What difference has universal health care, SHA, made in your facility?
Okay. Thank you, His Excellency. So to just begin, here at Ruto Hospital, we do have a good expansion of services, and that's all in contributions that we've had from the SHA reimbursement and also the expansions on the PHC services that we have. In addition to that, we started with 200,000 that we were getting in a year with the NHIF, but now with SHA, we have between 5.5 to about 6 million that we've been able to have an increase when it comes to SHA. In addition to that, we've been able to do a lot of expansion of services, like I'd mentioned. We'll be able to have the services where we were able to have before the TB on the outpatient, and also the in NCDs as well. So in addition to that, we were able to have addition on the theaters that we also have, the NBU that we're also able to manage to have our bed capacity that is about 10. And the most importantly is our workload that we're able to have our increase of our patients from 200 to now 400 patients per day.
So you're telling me that you used to get reimbursements of around 200,000. Is that correct?
Yes, His Excellency.
Per month?
Yes, His Excellency.
What is your reimbursement now from SHA every month, on average?
From SHA, we about between 5.5 to 6 million a month.
So it's gone up.
It's gone quadruple up.
How are you deploying that money that you get in your facility? For what are you using that money?
Okay, so for one, we have been able to expand our services. That means from our end, we were able to have our lab machines that we were able to buy too for the full hemogram and also the biochemistry machine as well, and that has expanded our services when it comes to Ruto service. Then number two, we've been able to do the theater. We've been able to expand our services on our end, and also the NBU that we're able to expand to 10 bed capacity. So for Ruto Hospital, the reimbursement that we've been able to get for SHA, it has been able to expand our services and also be able to have our areas where when it comes to not only equipments that we're able to get from the SHA reimbursement, we are also able to get the gaps that we're able to have into the service delivery here in Ruto Hospital.
So, Ruto is it a dispensary or a health center?
It's a health center.
So when I made a commitment,
but with the addition of...
Yes, sorry, please continue.
Sorry, with the addition of the services that we'll be able to have, the hospital will be able to move from the health center level 3 that is in now to a level 4 that is going to be comprehensive of all the services.
So my question to you, Alice, is that...
Yes, His Excellency.
I did make a commitment to you and to facilities like yourself that we are going to have a system that will improve service at that level, at level 2 and level 3. Can you confirm that that has actually happened?
Yes, I can definitely confirm. So, for example, right now, the theater machines that we're getting installed here for the theater and also for the NBU, they're actually coming from the NESP. That's the National Equipment Service Program that we are very glad, His Excellency, to be able to support the facilities when it comes to equipping the hospitals. And also with the contribution from the FIF that we're also getting in the hospitals, we're able to also expand the services and the equipments that are needed. And also to get the medication, Your Excellency, I can be very proud and actually say with a lot of confidence that I don't miss drugs here in Ruto. I don't miss that's non-pharmaceuticals and lab reagents. So those are the 3 areas that I make sure that when we are doing our reimbursement that is coming from SHA, our FIF that we get from the hospital, we make sure that it's getting back to the patients and also the community at large. Then to also mention, we do make very good food, His Excellency, for our patients.
Thank you very much, Alice.
Our maternity.
I want... thank you very much, Alice, and my very best wishes as you provide service to Kenyans there, and good luck with what you're doing, and congratulations. Thank you very much. We're really proud of what you're doing
Thank you for this.
In Ruto. I want somebody live here who is a manager of a facility to be able to tell us here, you know, do we have a manager of a facility? Yes. Are you a manager of a facility?
I'm the County Director of Medical Services.
Proceed.
Yes, my name is Dr. Eliza Ikiara. I wanted to highlight some of our facilities, how they're doing before SHA. For example, Ugweri Dispensary, one of our, in Embu County, Ugweri Dispensary, which is a level 2. With NHIF, they never used to get anything, 0. But with SHA, with the PHC, they are getting around 6.4 million in a year. And also we have Gategi, that's a health center, Gategi in Mwea sub-county, which gets around 9.6 million now in a year. And the other one that we have is Kianjokoma, which is a health center in Runyenje sub-county, which has around now 10 million. And with that, they are able to procure medication, lab commodities, and non-pharmaceuticals for themselves and don't have stockouts anymore that we used to experience before. And also, they are able to also, for example, Gweri was able to install CCTV cameras in the dispensary.
What do you have to tell to the people who say SHA is not working?
And for me, I would say for us in Embu County, we have seen the difference. We are getting, our revenue has increased exponentially. We are not running out of drugs. We have refill rates of 80% and above. And even Embu County scored highly in our pharmaceutical dispensing rate that was done by, we had 72%, meaning 72% of the clients get the whole prescription filled at the facility.
Do we have, thank you very much, Daktari. Do we have a facility manager? I want somebody who runs, do we have somebody here? I really want somebody who runs. Do you run a health center? Yes, please give her the mic. Tell us your experience.
Thank you, Excellency.
Your name first.
My name is Gladys Chebet. I'm the facility in charge, Ngaira, which is just across here.
In Nairobi?
Yes.
Okay.
Just here at Technical University.
Okay.
Yes.
Proceed. What is your experience of the difference? Has SHA made any difference in your facility?
Yes. Before SHA, we actually used to get some funds from Danida, which was around 270 to 50,000, which actually never used to cover everything. But right now, I've been able to claim over 7 million. And we've been able to procure a full hemogram machine. Our laboratory is working optimally, and our pharmacy is full. In Gaira, we are running a NCD clinic, which has around 1,600 clients, and they are all going home with very good drugs. And SHA in our work, yes.
In short, SHA in our work?
Yes.
Okay.
And we have been able to improve our infrastructure. Yes. It used to be a very old facility, but right now, it's good.
Very good. Thank you very much. Do we have another person who runs a health facility? Do we have a person who runs a health facility? No. Okay. Let me go to the second item. You know, KEMSA, I have said here that KEMSA has increased the refill rate. I made a statement earlier. And Wako, the CEO of KEMSA, is here. We have taken refill rate for requests from hospitals from 40%, meaning that if a facility requested for 10 drugs, we could only provide 4. We've moved that to 91%. And among the best performing counties, and we must give credit where it's due, is Kilifi County. The governor of Kilifi is here, Governor Gideon Mungaro. Mr. Mungaro, Governor, can you tell us ama utueleze kwa lugha ya Kiswahili mambo vile yalivyo?
Thank you, Excellency. When I took over in 2022, August, the first few orders, first we had a very big bill of 429 million inherited. We negotiated with KEMSA, but for the first 1 year and a half year, we were getting between 38 to 40 of our orders. But I remember after our last summit when you promised, because as a county we have really tried to buy from KEMSA, because we have two advantages, Your Excellency. Apart from when we started, we had only 38 to 40%, but one thing you can be sure, the drugs you buy from outside KEMSA, 10 million you buy from KEMSA, you spend maybe 30, 40 from other entities. So since 2025 coming 2024, towards the end of 2024, it started going up. The last 2 orders we did to KEMSA, we got 183%, and the last one we did a few months ago, we got 70%. Probably we tell Wako where he needs to improve is on surgical gloves, which we always have a challenge sometimes, and the other gloves, I don't know if the doctors call them what? Sterilite. Because sometimes you go, they are there, but you get number 7, and some doctors are very big hands, you need number 8. So maybe that's where we need some improvement. But I must say, since I came to office, Your Excellency, I bought drugs 1.6. I bought from outside before when we got only 38 to 40. But I have bought from KEMSA, and the worker will testify that I bought as a county drugs worth 1.6 billion and 80 from KEMSA.
Thank you very much.
Thank you.
Gideon Mungaro and I are not doctors, so forgive us if we don't know some of the names of the gloves and all that.
My CC, Your Excellency, can talk something. I know you wanted only facility managers.
Yes.
But my facility manager will return from the gate because they said they know him.
Okay.
But I can tell you something about Kilifi Hospital.
Okay.
Because it is completely a change when we started doing SHA.
Yes, Your Excellency, I can confirm here that there's been quite a transformation since we started receiving the SHA reimbursement. We have been able to expand our hospitals with equipment from 2 theaters. Now, our referral hospital, we are operating 5 theaters, which means patients don't have to wait for a very long time. Another hospital, we started with 1 theater, now we have 2 theaters. And in the 3rd hospital, we now have 4 theaters. And all this equipment we're buying based on the reimbursement we're getting from SHA. So there's a lot of transformation. And as far as the procurement of drugs is concerned, through KEMSA, Your Excellency, we've seen tremendous improvement. From the 40% which we started with, to now we're getting 83% of our orders. And even with that 83%, we still get back orders to fill the difference, which we still distribute to our health facilities. And for the SHA reimbursement at our primary care facilities, that has really improved our drug availability because they are able to spend at source to procure the higher support staff with the money, and therefore we've really improved services using SHA. Thank you.
Let me ask you, are you a doctor?
I'm not a doctor.
You are a manager?
Manager, yes.
Let me ask you, before we did not have the law on Facility Improvement Financing Act. What difference has it made? Because under NHIF, money was being sent to the county. Then it was up to the county to decide which facility to go improve, which facility not to go improve, which facility to buy medicine for, and which facility not to buy. Today, every facility is reimbursed their money. Is that the case?
Your Excellency.
And how has that helped in making sure that there is delivery of service?
Your Excellency, the implementation of the FIF Act has tremendously improved. First of all, the fact that the facilities themselves are able to spend the money at source is an incentive for them to make sure that they generate more. Therefore, they contribute to recruitment of members to SHA so that they can be able to have more resources to spend. But more importantly is the fact that they are able to make the decisions based on the priority of the hospital at that moment. They don't have to consult elsewhere or wait for resources from the county treasury to make funds available at the facility. They're able to prioritize and act on the spot as they receive the reimbursement from SHA. Thank you.
Very good. I want to ask one more question to either a CC of health
Your Excellency, I wanted to add from where the CC, he didn't elaborate something. The Kilifi Referral Hospital, we used to collect about 1.7 million a month, and now we are at 30 million. Malindi used to collect 1 million, now we are at 16.5 a month. So that is the change I thought the CC will explain.
And that is the money, Gideon, you are using to improve the facility.
Yes, we pay even locum nurses from that money.
Yes, you pay some of your staff.
Yeah, and all the casuals who work in the hospital or contractual workers.
And also to improve the theaters
yes.
And all the other facilities.
Like the 5 theaters he was talking about, we just did them. They are 3 weeks old.
Using money reimbursement from SHA.
Generally, when we took over the county, the hospitals, the level 4 hospitals and the Kilifi referral were collecting in total 176 million in 2022 to 2023, June. Now we have collected 900 this year, 900 million from 176.
Okay. Let me ask one more, CC, because it's good for us to listen from practitioners on the ground, not people who are talking from political podia. Do we have? I want to ask a question, and I want a CC to answer me. Is it correct for me to say, just as I committed to the people of Kenya, that today dispensaries, health centers are more empowered to make decisions on how to use that money, which drugs to pay for, which theater to improve, what facility to improve in every facility? Is that the case, or they have to wait for a county to decide or for somebody else to decide? Are you a facility manager? You are a CC. Please tell us your name, and please help this audience and others listening to understand.
Yes, my name is Dr. Gregory Ganda. I'm the CCM in Kisumu for medical services. It is true that with the FIF Act, now facilities can make their own decisions. But it is even better because the facility board is made up of members from the same community. So they oversight these funds. So whatever the facility decides, the technical people make decisions, and then they get the oversight of the community. So the decisions about that funding and how that funding is spent is both technical, but also involves the community. So I can confirm that, yes, this is true.
So, and I remember giving an analogy that the same way you have a school management board helping us to manage our schools, to build classrooms, and to make sure that the facilities are there. Today, our boards, which are members of the community, they are the ones who oversee the money we reimburse these facilities. They are the ones to decide that we want to make sure that there are enough health commodities, that is medicines and all the other things. We need to repair, we need to buy this equipment. We need to buy the other equipment. That is the case, Daktari, is it?
Yes, that is the case. We allow them to make decisions, but of course we oversight them sometimes. Mm-hmm. Like for most facilities right now, in most counties have given a minimum, because sometimes they might decide, members of the community can say, build the gate and build the wall and all that, and then you don't have enough medicine. So we are giving them a minimum percentage. Most of us are doing 40, 50%. Mm-hmm. Half the money must buy medicine, because the biggest problem of Mwananchi is hakuna dawa. Mm-hmm. So we don't want anybody to come here and say hakuna dawa. Mm-hmm. Once that is sorted out, maybe you can paint, you can do other things.
Very good.
Thank you.
I want to ask one more question. Just sit down, Daktari.
Thank you.
Because, you know, we need to answer to the things that Kenyans want to hear. Number one, we said we are going to empower every facility to make decisions. We send the money, not anymore to the county, but we send reimbursement for every citizen a dispensary treats. For every citizen a health center treats. We send the reimbursement to that dispensary. If they treat 20 people, we send reimbursement for 20 people. If they treat 1,000 people, we send reimbursement for 1,000 people. But financing is not the only challenge. The other challenge is equipment. To be able to provide service, you need the theater, but you also need equipment. And this is what we did. And I want CECs who are here to confirm, and even our friends, the governors who are here to confirm. We did the following. We said that it is not possible for some of our facilities to buy an MRI machine, to buy a CT scan machine, theater machines, IC, whatever. Many of these facilities are expensive. They are in hundreds of millions, tens of millions, some of them in hundreds of millions. And so we agreed and we designed a program called National Equipment Service Program. Yeah? And how did we do it? We said, let us pool all our facilities and negotiate together with manufacturers. Because it is difficult for manufacturers to go and negotiate with a dispensary or a health center alone. But if we pool together through the economies of scale, we can be able to have the muscle to negotiate for better prices, better facilities, and also for the manufacturers. It is easier for the manufacturers to deal with us as one entity than to deal with us as individuals. They are assured of their money being paid, and they are assured that every facility is going to pay the rate. So, today we have equipment supplied by manufacturers, equipment that has not been paid by the facilities. In the past, under the MES program, Managed Equipment Service Program, we paid almost 63 billion for equipment, some of which did not work, some of which broke down and there was no service, some of which we did not even have the reagents and consumables, and it was very problematic. So we thought and said, let's do it differently. I want to know from either a manager of a facility or a CEC, what is their experience? How many equipments have they got? And what is their experience with the equipment that is being supplied under this framework? Do we have a manager of a facility or a CEC? I think I have some gentleman there. The gentleman in some brown, nice suit.
Asante Mheshimiwa Rais. Jina langu ni Daktari Martin Wafula, Mutuini Hospital. Kwa kweli ule mpango wa kuleta vyumba kazi kwenye facility zetu imetusaidia sana. Kwa sababu ya kwanza, hatujalipa hela yoyote ili tuletewe machine za upasuaji kwenye hospitali zetu. Kwa miaka ambayo nimekuwa hapa karibu nikifanya kwenye mahospitali kadha wa kadha, kutengeneza theater unahitaji pesa ya chini kabisa ni milioni 50 ili uweke theater ambayo ina vyumba kazi, ina mashine ya kutosha na pia ina instruments. lakini kupitia huu mfumo wa NESP, facility zetu, kwanza ya kwangu ambayo niko namalizia, nimepewa theater 3, na hizi theater 3 zinakuja na mashine ya kupeana anesthesia. Pia inakuja na mashine ya upasuaji ya kitanda. Pia inakuja na mashine ya kupeana mionzi, radiotherapies na x-rays. Manake hivi vitu baadhi yetu, Mheshimiwa Rais, baadhi yetu na ndugu zetu ambao wamekuwa kwenye vyuo vikuu wakisomea taaluma ya udaktari hawakuwa wameviona, ndio mara ya kwanza wanaviona kwenye hospitali zetu. Jambo la tatu, kuna baadhi ya mashine, kwa mfano endoscopy. Mheshimiwa Rais, mpango wa endoscopy, wa colonoscopy, hizo surgeries ambazo haupasui mtu, unatoboa kashimo tu alafu unapasua mgonjwa, baada ya siku chache ameenda nyumbani. Hiyo ni heko na ni kitu ambacho lazima tujivunie. Jambo la 4 ambalo mkurugenzi wa DHA aliliongelea, Mheshimiwa Rais, kwa mara ya kwanza kwenye hii nchi ya Kenya tuna mfumo, na mwenye anataka kujua aje Mtuini kesho ama aende hapo sasa hivi, mgonjwa anaonekana akiwa wapi? Nyumbani. Na hili limefanya tukapunguza idadi ya kupoteza wamama. Kwa mwaka mmoja miezi mitatu, Mtuini hospitali haijapoteza mama hata mmoja. Kwa sababu gani? Tunatumia telemedicine platform. Aidha, Mheshimiwa Rais, haya magonjwa endelevu, non-communicable diseases, haya magonjwa yamekuwa tondazugu zaidi, na jambo ambalo linatuzuia, tunao madaktari bingwa wachache. Kwa mfano, unaweza kuwa tuna daktari bingwa wa upasuaji wa ubongo mmoja ama wawili, lakini kutumia mfumo wa telemedicine ambao DHA imetupa, tunaweza ona mgonjwa mahali popote pale na ule daktari apeane mwongozo. La mwisho kwenye teknolojia ambao pia imekuja na SHA. Mheshimiwa Rais, tulikuwa na kitu inaitwa rejection rate ya claims, lakini kwa sasa tunaongea hivi, rejection rate yetu sasa hivi is less than 1%.
Pale Mtuini na pia kwenye mahospitali mengine ambayo ndugu zangu wako hapa, ukienda Mama Lucy, ukienda Mbagathi, ukienda Pumwani, hivyo ndivyo hali ilivyo. Thank you very much. Nimesikia kwa mara ya kwanza daktari bingwa. Utanieleza hapo nyuma ya hata ndio ni kusema aje. Sawa sawa, daktari bingwa. Let me ask, can I get let me ask one of the manufacturers, supplier. Can we have a supplier of theater equipment? Because that is what my brother there. Do we have a supplier here in this?
I can see a hand up there.
Do you have a supplier? One of the suppliers?
A supplier?
Are you a supplier? No. Are you a supplier?
No.
If you are not a supplier, please, let's be tuwe na heshima. So let's pick what first, because we want to know from our suppliers. Was any supplier invited to this facility? No supplier was invited. Because I wanted to know the numbers. Do you have the numbers of how many theaters, how many have been supplied in the country?
Yes,
how many?
Yes,
the number of equipment, the number of
Yes, Your Excellency. Under the National Equipment Service Program, we have supplied 52 digital X-rays. Your Excellency, we have installed 72 ultrasounds. We have installed 6 mammograms. We have installed 39 CT scans. Your Excellency, we have renovated and equipped 67 theaters. Your Excellency, we have established 157 laboratories, that alone, Your Excellency, worth more than 2.3 billion. Your Excellency, as the CEO of Mutwini was speaking, he mentioned specialized surgery. So specialized urology, as we know, prostate cancer is one of the big 5 cancers. We have installed 4 specialized urology theaters. There's something that they call a urology tower. Your Excellency, we have also been able to install 4 specialized ENT theaters. We've installed 4 specialized maxillofacial. We have also installed specialized cardiothoracic and vascular centers, 4 of them. Your Excellency, we have able to install specialized plastic centers, 4. We have also been able to replace the LINAC machine at Kenyatta National Hospital that used to break down often, Your Excellency. Kenyans know this story. Your Excellency, we have also been able to do 2 MRIs, and 2 MRIs are on the way by the end of this month. Your Excellency, in total, we've been able to install machines worth 9.8 billion shillings without the national government paying for it and without the county government paying for it. And Your Excellency, as you had mentioned, the game changer here is in the technology, the latest technology. And Your Excellency, one of the biggest challenges that we also have with equipment management is that the technology changes quite quickly, and most of our public hospitals are not able to employ what we call biomedical engineers to keep up with the latest technology. And so the game changer here is to keep equipment at 98% uptime without having to call manufacturers to come in and out to repair. Often, Your Excellency, the CT scans that were installed long time ago, 2 years down the line, they get broken down. You need another 16 million to repair them. You have to fly in an engineer from Japan or from Europe. And Your Excellency, we've been able to completely resolve that problem.
So, at the moment, under this program, we agreed that the equipment is placed by the manufacturer.
Yes, Your Excellency.
It is maintained and repaired by the manufacturer.
Yes, Your Excellency.
Consumables are provided for by the manufacturer.
Yes, Your Excellency.
All we pay for is for a service.
And when the service is offered?
When the service is offered.
And it is paid for by SHA.
If the service is not offered, we don't pay.
Yes, Your Excellency.
And it is paid for by SHA.
Yes, Your Excellency.
I don't know whether the CEO of Kenyatta is here.
He's in.
Yes. Kenyatta is possibly the largest public health facility we have in Kenya. Daktari Lesiambe, can you give us your experience as a manager of one of the largest facilities? How has your theater improved? How has service improved or not in Kenyatta? And then I want the CEO of Tenwek Hospital, one of the largest private health facilities in Kenya, to speak and tell us their experience. This is the largest public facility. We will also listen from the largest private facility. Yes, Richard.
Thank you very much, Your Excellency. Let me start by saying that Kenyatta National Hospital is the 2nd largest hospital in Africa. I apologize by, correcting you, Your Excellency, because it is the 2nd largest hospital in Africa. In terms of bed capacity, we are 2nd to Chris Hani Hospital in South Africa. Now, Your Excellency, when it comes to management of health services in Kenyatta National Hospital and providing quality health care, we have to have equipment. And at Kenyatta National Hospital, as we speak today, we have 32 fully equipped theaters from 12 equipped theaters in the last 4 years. And Your Excellency, I've had the opportunity to be in Kenyatta National Hospital for the 2nd time. I was in Kenyatta National Hospital as a CEO in 2012 and 2013. Today, I've come back less than 1 year. I want to confirm to you, Your Excellency, that it's not only the issue of having the 32 theaters, But what it means is that we are reducing the waiting time for surgeries, for management of our patients. It used to take a long time, it used to take long periods, and sometimes it used to compromise the quality of healthcare for our patients. Today, we have 32 theaters fully equipped, and there's no patient who can wait for more than 2 weeks before they're actually taken to theater. And on emergencies, it is done within 24 hours. Your Excellency, this has also assisted us when it comes to imaging. We used to have only one CT scan. Today, we have 2 CT scan machines, the most modern, in terms of healthcare management. And therefore, we don't have any patients waiting for CT scans to be done, images to be done, for us to have diagnosis, and for doctors and consultants, to make decisions on how they can manage them. We have gone further on a very, very sensitive issue, which has been causing havoc and I think a lot of concerns among Kenyans when it comes to cancer management. Kenyatta National Hospital in 2012 up to 2016 has only had one LINAC, or LINAC accelerator machine for management of or treatment of cancer. Until 2 months ago, now we have a second LINAC machine managing 150 to 200 cancer patients on a daily basis. Your Excellency, we expect also in the next 2 months, we are also going to get a third LINAC machine. Therefore, Kenyatta National Hospital, before September or October of this year, will have 3 LINAC machines. We will also get a PET scan before the end of this year, and we will never talk about challenges of cancer management or cancer patients' problems at KNH for the next 7 years. So as I conclude, Your Excellency.
Just for context.
Yes, Your Excellency.
Just for context, Richard, the LINAC machines, the theater machines, did you have to pay for them, or they are supplied under our NEST program?
The 15 theaters machines that we received from the suppliers of NEST, or National Equipment Service Program, were brought in free. In fact, what happened is that they brought all the equipments, including the tables, they also including the anesthesia machines, and all other equipments. What happens is that we have an arrangement where for each and every operation, they get a minimum of 15,000, or even sometimes a maximum of 15,000 shillings. If the operation is even going to cost about 300,000 or even 400,000, they only get 15,000. So the deal is actually too good for us. And that's why we decided to maximize getting all the 15 theaters. So we did not pay a penny for those theater equipments. We never paid a penny for the CT scans. We have never paid a penny for the LINAC machine. We have not paid a penny for the mammogram, which we have a modern advanced mammogram for breast cancers management diagnosis.
Can you give us your experience on SHA reimbursements?
Thank you, Your Excellency. I want to go back to 2013 when I left Kenyatta National Hospital. We used to operate under NHIF. We have a bed capacity of we had a bed capacity of 1,800 beds. Today we have 2,200, almost 2,300 beds at Kenyatta National Hospital. NHIF patients were only 60% covered. We had only 60% patients on NHIF at KNH. Today, under SHA, we cover 90% of our patients, or 91 to 92% of our patients under SHA. And we have managed to get, as I can confirm today, Your Excellency, we have received 4.2 billion shillings from SHA in the last 18 months. So, and I think as I've heard from one or two individuals from the county facilities, I want to confirm also that SHA works. And I can tell it to all Kenyans that we have had 1 million patients passing through Kenyatta National Hospital as outpatients. We have also had 900,000 patients passing through Kenyatta National Hospital in the last 1 year. All of them have been paid by SHA, including the emergency patients.
So, are you telling the Kenyan public that the 1 million people you treated in Kenyatta Hospital on outpatient came in, they were treated, given drugs, and they left without paying a penny, and SHA paid for them?
Yes, Your Excellency, I want to say this with no fear of contradiction. I've been there for the last, I think, 10 months, 11 months. That's what has happened. I can also confirm that 9 months ago, I was in Jaramogi Oginga Odinga Teaching and Referral Hospital. And I was there for 18 months. And Your Excellency, when I was there, we actually received, I was there when SHA started in 2024, and I left last year in June. We received 900 million Kenya shillings at Jaramogi Oginga Odinga Teaching and Referral Hospital in comparison to what they used to get under SHA, which was 266 million. Under NHIF, sorry, Your Excellency. So, and I'm also here with the acting CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital, and he knows very well that we did that job together, and it happened. So I want to confirm that SHA works, and the question you asked, if somebody tells you whether SHA works or not, it doesn't work. I want to say, those ones who do not live in Kenya, yes, probably SHA does not work for them.
Thank you very much.
Thank you, Your Excellency.
I want to listen from the CEO of one of the largest private hospitals in Kenya, Tenwek Hospital. And I remember Tenwek because when I met them, they told me they have a store full of IDs and title deeds. Bwana CEO, can you tell me the experience?
Thank you. Thank you, Your Excellency. My name is Ben Siele. I'm the CEO of AGC Tenwek Hospital that is based out of Bomet County. Your Excellency, Tenwek Hospital is a level 5 and has existed for the last 89 years. It's a mission hospital, and we now have a state-of-the-art cardiothoracic center. That's a level 6. The cardiothoracic center is actually the best facility in sub-Saharan Africa. And we are so proud of that achievement. And that has come through the collaboration with partners and also with the government and our church, which is the sponsor. So the experience that we have in Tenwek Hospital is that before 2024, before the rollout of SHA, every year we could claim close to 500 million. But last year we claimed 1.2 billion, which is more than double what we used to claim before. To June this year, we are about 600 million of the claims. We have received so far, for the last 18 months, we've received 2 billion out of claims that we've placed of 3 billion that we've placed with SHA. So that has really facilitated us big time. And like we said, Your Excellency, we are a mission hospital. And a number of the patients that come through our facilities, not only in Tenwek, but even for the faith-based hospitals, are patients who are really needy, and we cannot turn them away. We have to treat them. So what that did, Your Excellency, is when the reimbursement, because the reimbursement rates were really enhanced, it really helped us big time in the burden to treat these patients that were coming through the facility. And we are really happy and so grateful for that.
Let me ask you, Daktari, I was there to witness your, state-of-the-art cardiothoracic facility. Yeah? And I know you treat patients from almost the whole country, right? And sometimes even foreign nationals.
Your Excellency, so far we've actually treated patients from 14 African countries this year alone.
I hope you don't use SHA to pay for this.
We don't, Your Excellency. Those ones are paid for in cash or insurance.
By their insurance by their other facilities.
Yes, Your Excellency.
What happened to the big store of titles and the IDs?
Yes. So thank you, Your Excellency. And like I said, it really helped us big time to reduce the burden that the patients used to bear. And because we used to collect, they used to deposit IDs or collaterals, but since then, we have actually had to surrender the IDs or the collaterals that we had secured. And that has really helped the Mwananchi big time. Thank you.
Thank you very much. There is another facility, Kijabe, AIC Kijabe facility. I don't know. I asked this. I asked the good people here to ask the CEO because it is again one of the biggest private facilities in Kenya. I don't know whether the CEO is here. Yes. I want to understand, my good brother, what is the experience of Kijabe? I know you do some of the most complicated surgeries and you support a very big area and you are a private or faith-based facility. What is your experience?
Thank you, Your Excellency. My name is Dr. Watson Maina. I'm here representing the CEO who's out of the country. And I want to echo the comments from my friend that SHA actually is working in Kijabe Hospital. The patient experience has been such that when they come for chemotherapy, for dialysis, and for surgery, the biggest change that we noticed with SHA compared to NHIF was the speed of pre-approval, of the pre-authorization. We have had over the last 6 weeks, for example, mass accidents happening along the highway near our facility. And for patients who need to be rushed to theater, we have not had to delay at all. They have gone to theater, received the service, and been admitted to the ward. One of the biggest differences we noticed comparing SHA and NHIF was the reimbursement for critical care. You talked about critical care, Your Excellency, and I can confirm that the reimbursement supports admission to ICU, admission to high dependency unit, HDU, and it allows for the citizens to come and be admitted into the critical care facilities and has a very good reimbursement.
Thank you very much, Maina. We have in our midst our frontline, champions, community health promoters.
Your Excellency, before we go there, we have people online, and your question on reimbursement has triggered some reactions online, with some other hospital owners who are not here saying that they're not getting reimbursed, much as the ones in the room that have spoken are saying they're getting reimbursed. So it seems like there are two schools of thought, that we are getting reimbursed, we're not getting reimbursed, we've not received any money from SHA.
So can we tell us which facility?
This was from Karen Hospital.
Yes. Do we have them online? Do we have them online? Do we have the CEO of Karen online or somebody? Yes.
Your Excellency, while we were having the show, I think Dr. Gekonyo had tuned in and he mentioned it. So let me just read what he said.
Why don't you call him?
Oh, do you want me to call him? Okay.
Yes.
All right.
Put him on the line.
Yeah, I mean, what he said, are you aware that many hospitals have not been reimbursed?
Not many hospitals.
Okay.
We want.
Can you tell us how much SHA owes hospital services already, for services already provided? He felt that accountability for how much SHA owes.
No, let's not talk generalities.
Okay, let me just call him.
Call him, put him on the line. let him tell us what is the experience in Karen Hospital. And I want my team here, you know. The thing we do not want is people making general statements. Many hospitals have not been reimbursed. Which ones? You know, it's good to be. Please, Mercy, do you have your data on Karen Hospital? Yes. Can we have Kikonyo on the line?
That's okay. Not answering. Maybe he's in theater.
Okay, sorry. All right. So, but for clarity, you know, because we want to avoid generalities. Mercy.
Yes.
Can you give us the details of how much Karen Hospital has claimed, how much has been paid for the last 1.5 years?
Thank you, Your Excellency. So I've opened the system, and this is real time as at 21:26 today. Karen Hospital has submitted total value of claims 302,593,226 from the beginning of SHA. SHA has paid them 66.5%, so we've paid them 201,506,857 million Kenya shillings. We have rejected 9.5 million claims. That's just 3% of their claims. SHA has returned 40,284,778 to Karen to action. They have not yet actioned this claim.
For them to provide documentation?
Yes, to provide, exactly, extra documentation for ourselves. So what I am holding for Karen unreviewed is 51 million only.
So, Dr. Kikonyo, wherever you are, is going to be truthful. Yeah? And I have had this conversation with people with many generalities, you know. This is not working, that is not working, this is... We want to answer to facts. I was on my way to CHPs, our frontline champions. Do we have CHPs in the house?
Yes, we do have them.
Okay, I want a CHP to speak to us about their experience.
We have one
what
at the corner there.
The stipend has done to them, what the equipment has done to them, what the training that we have provided has done to them, and what do they see going into the future.
We have
do
a
we have any
gentleman
one
at the
of
corner.
them, you know,
We have
give them a
at the
mic,
back.
you know. There's a...
Okay, thank you, Excellency. My name is Benson from Kariobangi. I'm a community health promoter here in Nairobi City County. Starting on the stipend part, we are actually grateful. For the first time, we felt that we are being honored in this country as the CHPs, because most of the time, nobody used to value us. And it is a great thank you to you. And we can also not forget Governor Sakaja, when he was the senator, for pushing that particular kind of a bill. We are receiving 2,500 from the national government at Nairobi County and 3,500 shillings from the county government. That is summing up to 6,000 Kenyan shillings. We also have a phone, which we are really trying, and we are very grateful because you have promised us an advanced one. But the one we have at least has put things on track. As we speak at the moment, I'm able to trace my household, I'm able to report, I'm able to refer, and I'm able to do a follow-up whenever need is. And it is something that is very, very much grateful to us, because long time ago, we were working with a certain big book and a paper known as the MOH 100, whereby you can write, even you find you have write your girlfriend's name on that paper, and things are not working. So actually things are going on well on our side. From the kits that you people gave us, they are really, really helpful, not just to us, but also to the community. Right now, yule mama pale nyumbani anaweza jua hali yake ya sukari iko namna gani. Pale nyumbani, that old man is able to trace his sugar levels and is able to know if he is diabetic or not. And this one has also enlightened us, because long time ago, you know, we were just walking, mtu anakuuliza na niko na ugonjwa wa sukari. No, you wonder, how am I going to answer this particular kind of a person, because you don't have the facts to tell this person. But right now, confidently, you can answer somebody when they ask a question to you, because we have all those gadgets there in place. And what you can maybe just ask is that you keep on giving us the advanced ones, so that as time goes by, pia sisi tunajiditika.
Okay.
Yes.
I know we have committed, my good brother, can I have your name?
Benson.
Benson.
Yes.
Benson, we have committed to do two things. And by the way, just tell me before I say what we have committed. When you find a person, when you go to a homestead, you screen them either for hypertension or for diabetes or the next condition. When you find that they have that condition, what do? You refer them?
Yeah, the first thing is to refer them, because that is what our core task is.
Our training, your training.
Yeah, because as a CHP, we cannot treat, we cannot do. As we monetize something like that is happening, the first thing to do is to refer the patient.
Okay. So we have committed two things. We have committed to renew your kits. In another 90 days, I have asked the ministry to give you new kits, because the kits you are using are 3 years old.
Yes.
Some of the facilities, some of the items there, kidogo, imechapa.
Sio. Yeah.
And then we have also committed that every community health promoter, because they are helping us with making sure that we have access to health, each and every one of the 107,000, we are going to pay for them SHA, each one of them.
Sure.
50% by the county governments and 50% by the national government. The chair of the Council of Governors has confirmed to us that that has been agreed by the Council of Governors. Is that correct, Chair?
Yes, Your Excellency, at a flat rate of 660, we'll share and promise that all the CHPs will benefit from SHA coverage. Thank you, Your Excellency.
Thank you. And by the way, from Monday, you will be on cover. From Monday next week, every community health promoter in Kenya will be on cover. Them and their families and their dependents, they will be on cover, paid for by the government of Kenya. Yes, Benson, you still have something to say? Continue. Endelea. It is working. Don't.
Just one thing, Mr. President. As a CHP, also there is this particular kind of a question that we have been receiving it from the household level. And because I've gotten this opportunity, I'll be humbled if I can ask you that particular question.
Proceed.
Our community members. Our community members are asking this, and we are also asking on their behalf. SHA only allows us to pay in two bits. You can either pay in full or in half. And now, like that mama mboga, ama ule mtu anafua pale nguo pale nyumbani, maybe he or she has been given a monthly bill of 650 shillings, of which somehow it looks tricky. Is it a way where you can at least mpunguzia hiyo mzigo, badala alipe nusu, acha alipe mwezi kwa mwezi? Yes.
Thank you very much. Just for your information, we have assessments of up to 300 for those who cannot fully pay. So that is, the average is 660, but some of them will pay as less as 300, depending on their income, right? But I want you to see it in the context of what you are going to get. For 3,600, you will be treated for up to 1 million shillings or beyond. I mean, we should look at it in that context. And we have said for those who cannot afford to pay completely, assessed, we will pay for them as the government of Kenya. So that is the facility. I have Daktari Kikonyo finally on the line. Daktari, habari? Daktari, habari? Do we have a...
Hello, Daktari. Hello, you are speaking to His Excellency.
Yes, Daktari. I thought it should be on speakerphone. Yes, Daktari. Are you? Yes. Good evening. How are you? How do you put this on speaker? We need to put it on speaker so that we. Where is the owner of this phone? Can you come and ongeza sauti? Yeah, but can you put her on speaker? But it is not speaker. We cannot hear. Call her. Yeah, we need this story. Okay.
Your Excellency.
Let me, as we wait for that facility, I also want to